Good morning. Let's get started because we want to really be on time because several of our speakers are virtual. My name is Raj Dave. I am the chairman of the C3 course, and we every year we do a limb salvage program at C3 Congress in Florida. We obviously could not do it for this year because of the COVID, but we decided that we do it locally, and Dr. Shook, who is a faculty at Cleveland Clinic in Abu Dhabi as well as at Kent State University, helps me put together our limb salvage program for C3 Congress every year. And he's been very kind enough to help me put together this one. Our goal is to make this a recurring event locally every 3 to 6 months because I believe that the limb salvage issue really screams for teams, and we really need to work together as interventional physicians, vascular physicians, and wound care specialists so that we can save as many limbs as possible, and continued dialogue between the specialties and make this a multi-specialty event. So now I'll turn it over to Dr. Shook to say a couple words, and then he'll introduce our first speakers. We have a dual lineup. We have some speakers here, which are myself and Dr. Shook, who will be talking here live, and then our other speakers are virtual. So we want to be really on time to make sure that we bring them on as close to their allotted time as possible.
Thank you very much, Dr. Dave, and it is a privilege to be here, and I want to thank you for your invitation for this Saturday. Most importantly, I would really like to thank Dr. Dave and C3 for their continued and tremendous support of the foot and ankle community and their efforts to really try to integrate the education process with respect to the limb salvage patient. So our first speaker really doesn't need any introduction. Dr. John Steinberg, he is the residency director and fellowship director at MedStar Georgetown. He's the past president of the American College of Foot and Ankle Surgeons, and probably most notably, he's one of the leaders in our profession and internationally with respect to limb salvage, clinical management, and research thereof. Without further ado, Dr. Steinberg, and he's going to speak on functional limb salvage.
Great, Jeff, thank you. Can you guys hear me there?
Yes.
Okay. Jeff and Rajesh, thank you both. Loved your introductions focusing on the team approach here. Obviously, that's the perfect introduction for my talk because what we do for each of us doesn't happen without the team and without this being truly a multidisciplinary approach because there's no time in the diabetic foot to do things in parallel. The demand is that they be done in parallel. Sorry, that these aspects have to happen at the same time between the revascularization, between the limb salvage, the infection management, biomechanical management, and these are all just so key for what we do. I'm going to share my screen here now. Okay, screen share working okay? You guys can see the first slide there?
Yes.
All right. Well, good morning, everyone. I am John Steinberg, speaking to you from Washington, D.C. I'm fortunate enough to be full-time faculty at MedStar Georgetown University Hospital here in Washington, D.C. With just a tremendous team, like many of you work with, that's dedicated to this topic of limb salvage. And as a DPM, my key charge when I joined this team in 2004 with Chris Attinger, who's a plastic surgeon that had built this system at Georgetown, my key charge was, please help keep these wounds from coming back over and over and over and over again. Because as a plastic surgeon, I can cover these holes, I can do flaps, I can do grafts, I know how to do debridements, I can get these wounds covered, but they keep coming back. So please help me address the biomechanics. So that's going to be a big part of my focus today with this discussion. As you can see here from this little introductory video, this is my team in OR 21 at Georgetown performing a disarticulation amputation at the ankle. Amazing surgery, kind of feels surreal when you're doing this, and of course in the right patient it can be life-saving. But the reality is that many of us, and probably all of us, view this to some degree as a failure. We weren't able to keep this foot attached to this patient, whether it was ischemia or infection or biomechanics that ultimately cost us this foot. We failed. And that's where we would really like to look at, in this discussion for my introductory lecture, what could have been done in the weeks or months or years before this operating event in order to prevent it. We know that epidemiology amputation is very straightforward. These stats get covered over and over again in any diabetic foot lecture. And as an introduction to my talk, I would just direct your attention to the bottom bullet point that says very clearly 84% of lower extremity amputations are preceded by ulceration. So we need to work harder to heal ulcerations. And we need to do it early, and we need to do it often, and we need to do it even in the pre-ulcerative state for a lot of these high-risk patients with diabetes. I would tell you that as I get farther into my career, I get more and more aggressive with doing prophylactic and preventive surgeries in patients who may not have an ulcer at the time, but we know it's coming, or they've had it in the past, and we know it's coming back. We try to get real aggressive with these corrections. So what are the reported risk factors for ulceration? They're numerous, and they're pretty straightforward, and they don't change a lot. Literature has proven what the key top ones are, and I've listed them for you here, but I color-coded the ones in red because those can be fixed with surgery. With a good foot surgeon and with a good vascular specialist, we can address vascular disease, we can fix their functional foot deformity, we can address their abnormal pressures on the plantar forefoot and midfoot, and we can prevent an amputation by doing that. This is another slide that really doesn't change very often. The data here is pretty basic, pretty straightforward. The pathway to ulceration and amputation of the diabetic foot starts with high foot pressure in the face of neuropathy, moves on to skin damage and ulceration, and in the face of vascular disease, these ulcerations will fail to heal, they'll become infected, and lead to an amputation. This gray zone at the top left is where I try to focus a lot of my attention and time in my specialty of podiatric surgery, because if we can fix the high foot pressure, we can address or reduce the callus and skin trauma, and we can prevent the conversation of ulcers that fail to heal leading to amputation. So this is where we try to really focus a lot of our efforts when possible. Instead of playing make-up, catch-up game, let's stay ahead of the curve. So an example here, plantar ulceration, you can predict. I can sit down with one of my first-year residents or sit down with one of our third or fourth-year medical students and say, hey, let's look at this slide. Let's talk about the mechanics. Where's this foot going to ulcerate? Even the third-year student can pick out the two spots where this foot's going to ulcerate. It's going to be the plantar medial hallux IPJ from the hallux limitus and limited range of motion, and it's going to be the plantar second metatarsal head where the patient has a dislocated, contracted hammer toe from a metatarsal phalangeal joint deformity. These are simple, straightforward, everyday podiatric surgeries that we do in the non-diabetic population, and these should be fixed in the diabetic population as well, not for the cause of pain reduction, but for the cause of preventing an amputation. So the equation here of how this progresses, we know that in addition to ulceration, we oftentimes deal with Charcot, and this will be discussed later on in the day by several of your speakers. The conversation here is discussing the etiology and the pathway here. Again, the pathology in the diabetic foot is by no means rocket science. It's pretty straightforward. When you put together the fact that they have neuropathy and ischemia, and now we combine that with biomechanical deformities that might be related to those previous two factors, this becomes a compounded tissue breakdown that leads to Charcot and ulceration. So you can see here this calcaneus being pulled upon by the tight Achilles tendon, the Achilles tendon being tightened by glycosylation from hyperglycemia. This all just kind of leads to a downward spiral of events. So both introductions by Rajesh and Jeff talked about the LimSalvage team. Our team at Georgetown is just such a passionate, driven team, and I will tell you that the ones that I've underlined here at the top are all direct employees of our LimSalvage team. So we have full-time faculty, nurse practitioners and nurses and residents that are dedicated to our LimSalvage team. They're not on plastic surgery at that month. They're not on podiatric surgery that month. They're not on vascular surgery. They're on the limb team. And it's a really, really neat dynamic service. We employ vascular surgery, We employ interventional cardiology. We employ plastic surgery and podiatric surgery, as well as our own prosthetist and orthotist. And we even recently brought on a full-time rheumatologist for a lot of the difficult leg ulcers that we deal with in coagulopathy and vasculitis. So the ones below the screen are immediately available, but they are not directly employed by our limb center, as in we are their direct reports. So a case study example for you that really kind of in a nutshell gives you a quick jump start on what my thoughts are on diabetic foot. 39-year-old male, plantar ulceration that's been present for about a year, comes into our clinic, and we, of course, do our proper evaluation. We evaluate neurovascular status. We do appropriate debridement and local wound care. Week after week, we get up to the 4-week mark, and this is as good as we can get this patient. Blood flow is great. Obviously, no infection. X-rays look fine. But this is a biomechanical etiology for this ulceration. And if we don't address that biomechanical etiology, then eventually we're going to end up with a osteomyelitic situation and probably an amputation. So we quickly moved after a month of attempted local wound care that clearly wasn't working. We moved to the operating room and we did a percutaneous tendo-Achilles lengthening. You can see here we generally use the modified triple hemisection percutaneous hook to release the Achilles tendon at 3 sites. The posterior leg, this can be done in a prone position, obviously very easily, but we usually do it in a supine position and just elevate the leg and do it upside down since it only takes a couple of minutes. With this simple triple hemisection, you'll get about a 27% reduction in the plantar forefoot pressure, drastic change in their dynamics because we're allowing that ankle to go through its full normal range of motion rather than stopping at neutral or less than neutral, which would increase that push-off pressure to the forefoot and midfoot. So back to our patient who, again, had failed wound healing for a year. We can see here we've done a debridement, we put a tissue graft on, but most importantly, we did the tendo-Achilles lengthening. And with that, you can see after 2 weeks and after 4 weeks, we progress on to complete healing. Just a great example of simple approach to biomechanics in the diabetic foot that if we had ignored this and not done this brief tendo-Achilles lengthening surgery, we'd probably still be looking at a hole in the foot or even worse, an amputation. So in my remaining time, I want to try to go through 3 very brief topics that have really, in my practice, evolved drastically from where I started. And I think our literature supports these in a great degree now, and perhaps even employing this at an earlier time frame for some of these patients. So these 3 items of antibiotic spacer, FDL tenotomy, and vertical contour calcanectomy are 3 key procedures that I really feel are great benefit to this population I want to share with you. So we've published beginning in 2015 with posters and 2017 with peer-reviewed journal articles in International Journal of Surgical Case Reports and Journal of Foot and Ankle Surgery. Very strongly our opinion now on using polymethylmethacrylate antibiotic impregnated bone cement spacers. The world of antibiotic spacers in the diabetic foot has really gone full circle, and we've tried the cement, and then we went to absorbables, and then we tried different improved absorbables. I would tell you, I've come full circle back to bone cement, the non-resorbable type, impregnated with antibiotic, and I'll show you how we've modified how we use this. So the dogma that I grew up with as a resident said that spacers are always temporary, that resorbable is probably better so you don't have this block of cement sitting in the foot long term, that whatever you do, you should eventually come back and fill the gap with a bone graft or do a fusion, and that essentially the spacers don't provide any biomechanical function. I would tell you the fact of what we're publishing in our literature now and putting out from Georgetown is that these spacers can and oftentimes should be permanent. Polymethylmethacrylate actually is probably, in my hands, the better option because it doesn't have drainage and won't cause wound complications. You're not at all obligated to come back and fuse these patients, particularly in the elderly population. Perhaps if you're dealing with a diabetic complication in a 40-year-old, you may have to look at some type of fusion, but in the 60, 70, 80-year-old population, I generally don't find a need for fusion. And then the spacers do provide function. These are viable, functional devices when implanted correctly. So our evolution of antibiotic spacer use, you can see here, at first we were doing polymethylmethacrylate on chains, and then we decided that was a bit of a nuisance. So we started using some of these absorbable pellets, as you can see here at the fourth metatarsal phalangeal joint. And now, as you can see here at the first metatarsal phalangeal joint, we're really just recreating a 30% smaller version of the bone we removed, in this case, the first metatarsal head in the proximal phalanx space at the first metatarsal phalangeal joint. And we're creating that with polymethylmethacrylate and having it serve as a functional spacer. Great case example here for you. First metatarsal head osteomyelitis and a neglected ulceration. Patient who's already had a fifth med head resection from osteo and has a miserable cavus foot type. So we had to take out the whole first med head because of osteo, which is a tragic biomechanical loss to this patient's foot. So now he has only a second, third, and fourth metatarsal head remaining, which is kind of a doomsday scenario for the forefoot. We put a temporary antibiotic spacer in, as you can see on the photo to the right. And then we eventually, after about a week-long stay in the hospital, came back, redebrided, washed out the wound, replaced the spacer with a smaller version, and put a little temporary K-wire across it. Did a V to Y advancement flap to cover over the wound, and kind of held our breath, knowing that this patient already has a fifth med head out and has a cavus foot, that we were expecting this was going to be a rocky course post-op. And this was one of the early cases that convinced me that these spacers do have a biomechanical functional weight-bearing load, because at 2 months he's healed and looks great, and we hopefully expected that. But at 3 years out, and now this patient is 6 or 8 years out, this patient has intact spacer, no transfer lesion, not even a callus underneath the second or third metatarsal head. And given the fact that he has the first med head resection in addition to the previous fifth med head resection, I fully expected he would have transfer lesions and pressure 2, 3, 4. So this was one of the early cases that really convinced me that these spacers can serve an actual functional role. Next, very briefly, I want to talk about an old school procedure that I'm really trying to emphasize and bring back to the table, is Flexor Digitorum Longus tenotomies. By no means is this a new procedure, or did I invent this. Been done for many, many decades in our profession and others. But the simplicity by which you can employ this is the part that we're trying to really push at sessions such as what we have today. So when we do a partial forefoot amputation, there are biomechanical consequences. And one of the most common, particularly from our first ray amputation, is that the remaining toes that are probably already somewhat contracted will contract even more. And probably the most common area that we see a transfer lesion is not even submed head, it's at the distal tip of the toe. And these patients have a flexor substitution where that flexor digitorum longus tendon is overcontracting and becomes a fixed contracture eventually and creates these distal toe ulcers. So our routine was to schedule these patients when it was identified, schedule them for the operating room, get their medical clearance. And I had routinely situations like what you see on the screen here, where we would lose toes to amputation because we were waiting so long for their medical clearance and waiting so long for the operating room space to open up, that by the time we finally got to the operating room, it was an amputation that was necessary rather than an arthroplasty. So I, by no means, am here to tell you that we don't do regular hammer toe surgery anymore, as far as arthroplasty and pinning and getting beautiful straight toes. But I would say far more commonly now in the diabetic foot population, we do an in-office percutaneous FDL tenotomy. And many like to do this with a beaver blade or a 15 blade or an 11 blade. I've had a lot of skin tears from that, from these folks when you hyperextend the toe to release the tendon. And you end up having to suture when you didn't expect having to suture, and it makes a simple office procedure rather complicated. So at this point now, I've taken Craig Kamast and others' approach to use an 18-gauge hypodermic needle as my blade to do the tenotomy. Here's a brief video to share with you how this works. Literally is something that we'll do on the same day that the patient presents. This is not something we separately schedule. Brief written consent form. We mark the site. I'll prep with betadine. And the key thing here with the 18-gauge needle is just to go just barely below the skin. If you go too deep, you'll be right on the bone and you'll miss or go right through or pierce the tendon. So you want to just barely go through the skin and then start moving side to side. If you watch my left hand, the thumb, you'll see in just a second, you'll see that release start to occur. There we go with the release. It's such a great procedure for the patient and for the physician because you just get that immediate sense of benefit, and the patient can visually see that you have taken a bent toe and helped to straighten it and release the tension. Just a simple procedure that literally, as you can see, takes just a couple of minutes to do. Here's the reasons why we do this procedure. You can see the FDL tenotomy in this individual, top and bottom, 2 different patients who presented with ulceration. So rather than booking them for the operating room, we scheduled and did an immediate Flexor Digitorum Longus tenotomy for these patients. And what we were able to accomplish at their 2-week follow-up visit was complete healing. So rather than having that risk of waiting for pre-op, waiting for clearance, dealing with possible infection, we got immediate healing for these patients. Finally, the vertical contour calcanectomy, very straightforward procedure, just a modification of what we've already been doing for calcanectomies, but we got very frustrated with calcanectomies with avulsion fractures of the calcaneus, with failure to be able to close the wound. It's a terrible site to do a flap, and we know that heel ulcerations are some of the worst limb-threatening infections for these patients. And once you have a patient who's sick enough to develop a plantar or posterior heel ulcer, you know there's likely many comorbidities that are putting them at increased risk. So our dogma here of what we used to do for calcanectomies was to address this with a minimal incision, to do minimal bone resection, to preserve the Achilles at all cost, and to use a free flap to cover this big gap and put them on 12 weeks worth of IV antibiotics. What we do now instead is we make a wide, long incision extending up the posterior leg onto the plantar foot. We take usually 50, 60, or usually even 70% of the calcaneus bone out. We recontour that to a smooth weight-bearing surface. We resect and do not reattach the Achilles tendon. This allows us to primarily close the wound, and it allows us to send them out on a shortened antibiotic course, usually just 2 weeks of oral antibiotics rather than long-term IV. We've published on this extensively now with 2 papers looking at both the technique and the outcomes. Pretty straightforward in how this goes. Just to show you the importance of this in just a brief case, large plantar and posterior heel ulcer, miserable situation mechanically, and how we're going to close this. If you take enough bone and if you create these full thickness medial and lateral flaps, you can primarily close a wound even as big as what you see on the left with the closure that you see on the right. So a well-planned incision that truly creates these large medial and lateral full thickness flaps. Take out enough heel bone to get those flaps to oppose, and you can take this all the way to closure. Another example here, wide resection of ulcer and non-viable skin, wide exposure of these flaps, aggressive resection and planing of the bone to recontour it so that it's proper for weight bearing eventually for these patients. You can see here the initial cut. It takes out the entire posterior tubercle of the calcaneus. Seems very aggressive and perhaps irresponsible at first, but once you do this and realize these patients can have a functional gait pattern, and instead of putting them through a free flap that's probably not going to have long-term durability, we can close it with their own skin. You'll start to really buy in to this procedure. So again, here, a similar patient focusing on recontouring that posterior and plantar calcaneus so that it becomes kind of a miniature version, about 30% of what it originally was, but a similar shape, so that we keep that plantar weight-bearing surface so they're not walking on a spike or a tubercle. You can see here the old school calcanectomies were minimal resection. These would frequently result in avulsion fractures and tongue-type fractures because the Achilles tendon is still attached. Then we started to get more aggressive and take out most of the Achilles tendon, but we ended up with plantar and posterior spikes of bone. Then we went to a total vertical calcanectomy, which is headed in the right direction, but this is essentially what I would suggest is the best contour for calcanectomy, or even more aggressive than the bottom right yellow line, to really take out as much bone as you need in order to get direct skin-to-skin closure from those medial and lateral flaps. The example here showing the cuts, the yellow is the primary cut, red secondary cut, and the blue is the tertiary cut. Really, I would tell you the key thing for diabetic foot for me, we all think it's so savvy to say that it's cool to think outside of the box. There's no need to think outside of the box with a diabetic foot. All the answers are right in front of you inside the box. This really is a matter of addressing infection, a matter of addressing ischemia, and a matter of addressing biomechanics. This amputation that you see in front of you, you can see was a result of all of those. Infection, ischemia, biomechanics. And if we can get aggressive about addressing biomechanics with some of these simple procedures that I've talked about in this introductory lecture, and we get excited about really intervening early for the diabetic foot, then we can put this all together as a team, and we can prevent these patients from going on to amputation. My final example here for you is this patient, where you can see that essentially we've taken this ischemic, early infected, biomechanical originated wound, debrided it, revised it, revascularized it, and grafted it and closed it to the point that really the foot on the left and the foot on the right, it's amazing to see the impact it makes just on the skin contour and the overall skin health. It's like a total different foot by the time this limb salvage is completed. So this all can happen, but as I talked about in the introduction, it has to happen at the same time. We have to be working in parallel, and that's why the importance of what Rajesh and Jeff talked about here, and the reason that we're all here to discuss this morning is that we have to be a team, and this has to happen together, and it can't be my patient or your patient or his patient or her patient. It has to be our patient, and we have to be working together in concert to really make this happen. My email is here for you. I'm available and happy to respond to questions, and I think we have a few minutes to discuss some questions from the audience. Thank you all so much for the invite.
Thank you very much, John. Any questions from the audience? There is a mic in the back. If you want to ask a question, feel free to go up to the mic. Jeff?
I have two questions. I don't know if you can hear me. One is,
Yeah, I can hear you.
okay, do you ever, I see patients where we do isolated FDL tenotomies, for instance, on the second toe, and then 9 months later we've got it on the third toe, and it kind of moves across the board. Have you ever considered or done a retromalleolar or posterior tibial, just a pure tenotomy of the FDL tendon to try to avoid that sequential ulceration of digits? And then the second question is, could you comment a little bit on the function of your patients with the vertical contour calcanectomy and any suggestions that you routinely get from your prosthetist?
Thank you. Both great questions. So the FDL tenotomies, I would tell you, I feel so much safer doing it at the digit level, knowing that there's really nothing there for me to damage as far as important linear structures for neurovascular function. So I would tell you that a lot of times, as you point out, we do the second toe, and then, of course, you realize that, wow, 3 and 4 are starting to contract, and then 2 months later, 5 starts to contract. But I would say that I do oftentimes go ahead and just do all remaining toes on that foot at a single stance. But if there's an open ulcer, I will routinely just do the one toe that has the ulcer. And then once that is healed, then perhaps a couple of weeks later, come back and do the remaining toes. Because I would agree that's something that does happen is we celebrate success of, great, we did our tenotomy, we healed the second toe ulcer, and now they come back 6 months later, they've got a third and fourth toe ulcer. So you do have to think about it globally. I have not done the actual source tendon at the level of the ankle. Interesting thought process, but I guess I'd be nervous about the logistics of doing that percutaneously. But your question about the calcanectomy, yeah, we do thankfully have our dedicated prosthetics and orthotics team that's there with us in the clinic. It is an individual that when you do these vertical contour calcanectomies, or really any calcanectomy for that means, you're going to likely be casting them for a period post-op for a few weeks until you get healing. So total contact cast from me usually for 4 to 6 weeks. And then from that, they graduate into a crow walker boot, which they're going to use for 6 to 12 months. And at that point, if we really feel comfortable and the patient feels comfortable, we may progress to an AFO or an Arizona brace or a shoe with appropriate orthotic. But as long as you've got somebody, you do the casting for the 4 to 6 weeks, and you've got somebody who can make you a good crow walker, which nowadays is pretty commonplace, you can feel safe about your post-op course for vertical contour calcanectomies. But I would say that crow walkers is kind of our go-to for the immediate 6 to 12 months post-op.
Dr. Richards?
In regards to doing surgery versus offloading with your diabetic patient, do you try offloading with a shoe or with a total contact cast before proceeding to surgery?
Yeah, thanks for asking that, because I know my lecture comes off sometimes as aggressive, and it's like, oh my gosh, this Steinberg guy is taking out every diabetic patient to the operating room and fixing their bunions. You're absolutely correct that with every procedure that we discussed, these are folks who have failed conservative care. So we do a lot of shoes and a lot of orthotics and a lot of offloading, and certainly lots of total contact casting. But it's if the writing's on the wall and they healed their ulcer once with a total contact cast and now they're having a recurrence, that's somebody who needs to go to the operating room to fix the cause of that recurrence. Or if you have the patient who has significant sensory loss and you're starting to see a callus that you followed for years, that now the shoes and inserts won't provide enough offloading and it's starting to have pinpoint bleeding and you're debriding it to the point that it's almost a break in the skin, those are folks that I'll say, hey, let's go do a tendo Achilles lengthening, or let's address your metatarsal contracture, or let's fix this toe on a planned, scheduled surgery without you having an open wound, rather than waiting another couple of months for the inevitable that we know is going to happen. So I do get pretty aggressive on those, but you're exactly right. They all have failed some course of appropriate conservative care first.
Dr. Harrison, any comments?
Yeah, I just have a question for John. Do you use any sort of gait analysis or pressure mat devices in sort of the patient with neuropathy to evaluate, maybe some of your planned procedures or offloading techniques?
Yeah, great question. If you ask me in a month or two, my answer will be yes. We just ordered up a ton of we're spending some of our research foundation money we've been sitting on forever, and we just ordered up like $30,000 worth of 2 systems. We got a Bluetooth 3-sensor system that they wear when they're walking, so we can monitor for frailty and gait pattern. And then we just ordered a plantar pressure assessment system that it's portable, that we can put down in the hallway and have them walk on post-amputation or post-procedure. So the cost and the logistics have prohibited us from doing it earlier, but I would say, in a perfect world, we'd all be doing it for these patients. I know Bijan Najafi has done some great work on balance and frailty and gait pattern, and has really shown us how important that is for this population. So my answer is yes, in 2 months.
John, thank you very much for your input and sharing with us this morning. We look forward to getting you involved further down the line with our upcoming programs. Thank you very much.
Great. Thanks so much, Jeff. Appreciate it. Well done.
Okay. Thank you very much, John. Let's move on to try to keep on time. My goal today is to talk about revascularization. So if they can pull up my slides. Yes, so you all know the critical limb ischemia. These patients present to us with either rest pain, ulceration, or gangrene. They may present as multi-level disease, or they may have preserved flow all the way through the popliteal artery with below knee disease. I will show you some data is that not only that these patients have potential for limb loss from critical limb ischemia, they also have potential for contralateral limb loss. Their morbidity and mortality is really high. And if not emergent, revascularization is at least urgent, whether it's surgical or endovascular. And then we should not forget that many of these patients are diabetic, and adjuvant medical therapy is significantly lacking, especially in these diabetes patients. And wound and infection management is very, very important. If you look at the patient's mortality with critical limb ischemia and compare that to cancer, you can see that you are higher than lymphoma, you are higher than bladder, you are higher than uterus, you are higher than Hodgkin's, testis, thyroid. So it really poses a significant danger to these patients and have very high rate of amputation. Can we improve the outcome? This is one data set. This comes from the task document, and you can see that patients with primary treatment with amputation is almost 25%. And even after revascularization, you still end up having 30% of patients who are alive and amputated, and 25% of patients die just after 1 year. There still exists a significant variation in the use of lower extremity vascular procedures for critical limb ischemia. This is a very important paper from Circulation. This data is a little bit older, but still this situation exists. Here's 20,000 patients with peripheral arterial disease who underwent major leg amputation. And you can see that the amputation is vascular intervention in year prior to the amputation only 46% of the time. 54% of the time, patients were amputated without any vascular intervention prior to amputation. To make it even worse, even out of this 46%, 17% of patients had diagnostic procedure only, and nothing was done. So you can see that we are almost talking about only 35% of patients who we attempt to correct ischemia. If we divide the country up by the degree of vascular revascularization procedures in patients with critical limb ischemia, even in the very high intensity regions such as Washington, D.C., for example, only 60% of patients undergo vascular revascularization before they are offered amputation. Here is the map of the country, and you can see where we are. We're sort of in the middle. We're around 40–50% of patients in our central Pennsylvania where we offer revascularization procedures. So we need to go from somewhat from yellow to orange to at least get to 60% to get there. But in summary, CLI must be treated. Amputation doubles the risk of death over next year. Endovascular and surgical revascularization doubles the patient's survival compared to amputation. Now, of course, there's always this raging debate about whether we should offer patient endovascular revascularization, surgical revascularization, or patient should go for primary amputation. This is a very, very recent paper of 72,000 Medicare recipients who underwent treatment of critical limb ischemia. And you can see that the long-term survival and cost in critical limb ischemia management is comparable between revascularization techniques, whether it's surgical or endovascular, with lower major amputation rates following endovascular revascularization because we can go much smaller and much lower. Primary major amputation results in shorter survival, higher risk of subsequent major amputation, and higher healthcare cost versus patients who undergo revascularization. So clearly, we have some thing more to achieve than where we are today. However, there is many challenges of infrapopliteal and critical limb ischemia intervention. You can see that if we had patients like the one on the left, which is a very short occlusion of a popliteal artery, it'd be a very easy day. But most of the time, these patients have multi-level disease, long below-knee occlusions, heavy calcification, a complex diameter mismatch between these vessels that leads to substantial challenges in this type of patients. So it requires innovation, courage, and a great team. So what's new? So here's a no-option patient. So, you take a normal CLI patient, you send them to a endovascular or surgical specialist, and 30% of the time, they're going to tell you that, oh, there's nothing I can do for this patient. In fact, there are certain institutions, including mine, if we take our surgical colleagues, they will say 50% of the time there is no place for them to bypass, okay? So what do we do? Do we have any option for this absolutely no option patient? So this is a new technique that's coming down the pike where we are going to be able to connect artery and a vein to create a completely new flow to the patient's foot. That's called a LimFlow technique. So you can see that on the bottom is an artery that's completely occluded beyond the popliteal artery. We advanced a ultrasound catheter into that just above the occlusion, and we were able to see the vein from that ultrasound catheter. And then we deployed a needle. So now this is the ultrasound way. On the vein, we put in a metal probe that allows reflection of those ultrasound wave, and now we deployed a needle to go into the vein. Now we put a wire into the vein. Once we put a wire into the vein, of course, the veins have valves, and we need to destroy those valves so that we can reverse the flow. So this is a valvotome that goes in and cuts out the valves in the vein. So then now we can, the flow goes from the popliteal artery into the lesser saphenous vein and all the way to the foot. And then we, in fact, stent the entire venous system and extend the stent from the vein into the artery, basically creating a percutaneous bypass. So this is a procedure that's just gone into a clinical trial. We can do this procedure without the LimFlow device. However, it's very difficult. Here's an example of a LimFlow case. You can see this patient has a desert foot. There's nothing in this besides the collateral flow in this patient's foot. After the LimFlow procedure was done and the vein was arterialized, now this patient has a substantial flow. So this is the next generation. This is a follow-up of this patient. And the audio is not visible, but what you are hearing is a very loud posterior tibial pulse now. And you can see this patient's a very complex wound was able to be healed after this LimFlow procedure. So this is a procedure of the future. It's in the clinical studies now and it will be there. Here's some data from LimFlow clinical program. It's already a CE mark and available in Europe, and US pivotal trial will be ongoing. In a pilot study, there were 7 no-option CLI patients who were done. I participated in 2 of them. Average age of these patients, 85 years old, diabetes. Almost every single patient was diabetic. You can see Rutherford class for class 5 and 6, and a very high risk of these patients. These patients have achieved very high rate of complete wound healing, limb salvage, and a perfusion significantly improved at 12 months post venous arterialization of these patients. Here's another example. This is a patient who had a native femoropopliteal disease, and you can see there were multiple stents in this patient's SFA. They're all occluded, and this patient was then referred for a bypass because of critical limb ischemia. It's a diabetic patient. The patient had a femoral to anterior tibial bypass surgery. Just 5 months after this bypass, the bypass occluded. And this is why we're very, very leery about doing this very complex distal bypasses because there is especially in these diabetic patients, there is very high risk of occlusions of this bypass. And the patient was recommended to have left above knee amputation. So the patient came as a second opinion. And I saw this patient and I said, well, we can attempt to revascularize this occluded graft. And you can see this is a method to go through this occluded bypass graft. And then a infusion catheter was utilized and thrombolytic therapy along with a glycoprotein 2B3 inhibitor called RioPro, which was administered in this occluded bypass graft. Then we used a device called JetStream. This is marketed by Boston Scientific. They are exhibiting today to support this program. And you'll be able to see this device there. This is a device which cuts and aspirates at the same time. And you can see how it operates. It continuously removes the debris. You can see the jet stream device was sent through this bypass. And now you can see there's two distinct area of hyperplasia within this bypass graft which were uncovered. You can see there's a very tight stenosis distally, and there's a very tight stenosis proximally with thrombus. So this is a kind of situation where we would use a covered stent grafts to address this, and that's what was done here. This is a device called ICAST. It is a balloon expandable covered stent that was put in to take care of this fibrosis. There was another ICAST stent that was deployed proximally, and now you can see that the flow in the graft is restored. This patient's rest pain went away, and he had a small wound that was also healed up. You can see as all the way flowed very nicely into the foot. Now, another new advance is a pedal revascularization. So patent pedal loop arch predicts superior outcome in CLI patients with Rutherford class 5 and 6. So I'm going to show you data from a Korean article recently. And it's shown here a foot angiography and patency of the plantar loop. So you can have absent plantar artery, which is APA, or incomplete plantar loop, or complete plantar loop. And you can see that freedom from minor amputation, limb salvage, as well as survival depends on plantar flow. And this is where endovascular revascularization technique comes into play that can be complete patient's plantar loop. Now, it's clearly not possible every time, but we try very, very hard now to make sure that patients have a plantar loop patent, to be able to achieve a very high degree of limb salvage as well as a survival. Here's an example of a patient of mine. This is a 60-year-old male who had a rest pain on the left foot, multiple toe ulcer. He had a prior history of recurrent CLI, as we have seen in the data. You can see that the femoral-popliteal segment is pretty open. The patient has previously placed stent in the popliteal artery. Below the knee, left anterior tibial artery is totally occluded. The only patent vessel is the peroneal artery, and the posterior tibial artery is nowhere to be found. This is the foot angiogram. You can see the peroneal artery is patent all the way up to the ankle, and via the collateralization, you can see the plantar vessels, which is the medial and lateral plantar arteries, which are branched of the posterior tibial artery, and a small dorsalis pedis artery. So you can see what was done here. An attempt was made by me to cross the anterior tibial artery occlusion from above, and it didn't work. So a retrograde access was obtained into the dorsalis pedis artery with the use of an ultrasound, and a wire was advanced retrogradely into this anterior tibial artery occlusion, which also would not cross this occlusion. So we utilized a technique that we use in the coronary world called reverse cart, where we actually inflate a balloon into an occluded segment from the top, create a space for the wire to then enter retrogradely to be able to navigate through this total occlusion. So that was done here. That's what's being shown here. At the bottom of the screen, you can see there's a wire from below, there's a wire from the top, and a balloon is in position to create that space. Then anterior tibial artery was now able to be opened. There was a drug-eluting stent was placed proximally, and now you can see then the AT is open all the way. And now you can see the flow into the arcuate artery, but it's still not crossing over into the lateral plantar branches. So this patient was then brought back. This is a Japanese technique that we have transformed from a coronary procedures into the foot arteries. We use something called a Corsair microcatheter, which is a woven catheter made by multiple wires that allows us to navigate through these small vessels with the use of a polymer-coated wire called Filter FC. And now you can see that we went through the plantar loop, down into the anterior tibial artery, through the arcuate artery, back up the lateral plantar artery, up to the occluded posterior tibial artery. And now this wire is being advanced through the occlusion of the posterior tibial artery. That Corsair catheter, which is the Japanese microcatheter, is being advanced through this occlusion. And now you can see that the wire is going through this occluded vessel, and we were able to reconnect into the popliteal artery. So this is a procedure for interventionalists who are in the audience. Always should be done in an antegrade fashion, because if you do this procedure contralaterally, there is not enough length from the opposite groin to be able to go down into the patient's foot, come through the loop, and back up through the occluded vessel. Okay, so you need antegrade access, and you need a 6 or 7 French sheath to be able to accommodate all of this equipment to be able to complete this procedure. Now you can see that we have done an atherectomy of the posterior tibial artery, and now there is a flow from the top. There is a wire from the top, from above. There is another wire into the anterior tibial artery, and this is now a final result after atherectomy in a balloon of the PT, which is also open now, and AT, which is also open, and we have completed now the plantar arch for this patient. So as data that I've shown you, you can think about it that this is a patient who we have given the highest likelihood of limb salvage. We have reduced their mortality. So in conclusion, 1-year mortality and major limb amputation rates are over 25% with critical limb ischemia. There are still patients which are elderly, non-ambulatory, patients with heart failure, patients those who have dialysis and low BMI, they remain a problem. They still have high mortality. Endovascular therapy is the first-line therapy in CLI patients, replacing majority of the surgery due to lower morbidity of these procedures. New techniques and device improve procedural success in CLI patients. I'm going to show you several new devices in my second talk at noontime. And concomitant increase in endovascular intervention is now reducing amputation rate. Thank you very much. Any questions? Yeah.
Vascular studies in your practice, do you also get toe pressures? Is that part of
Yeah.
the study?
So, we use several different methods sometimes to evaluate the perfusion. So we do get toe pressures in our vascular lab routinely. There is also a new device that's in development now, which uses laser technology to evaluate the skin perfusion in these patients. So we sometimes utilize that to measure the skin perfusion at the baseline. Even after intervention, we will repeat the skin perfusion afterwards, to see if we have achieved as much revascularization as possible.
So occasionally the patient will have good ABIs, but the toe pressures are poor. Is that, I'm not sure if that's coming from the pedal area, the pedal arch, but is that something you could do a procedure for to improve the ischemic toe pressures if the ABIs are good?
Yeah, so, I will tell you that we almost never measure ABIs in our practice, really, because we think ABI is a totally useless measure, because 80 to 90% of the CLI patients are very, very heavily calcified below knee vessels, and ABI is almost always falsely elevated. So we always do a full duplex ultrasound, and we look at the skin perfusion to be able to decide, whether something should be done. I would say 99% of the time, we intervene on these patients because they have below knee disease and ABI is falsely elevated. So just ABI is not good enough for these patients. Okay, thank you very much. Now it's my honor to invite Dr. Shook. And Dr. Shook is going to discuss utilization and importance of Wi-Fi, wound ischemia, foot, and infection.
Thank you very much, Dr. Dave. Can everyone hear me okay? I'm going to ask a couple of questions to start off with. Does everyone in the room do limb salvage? Yes? Okay. How many of you still use the Wagner classification when you see patients in the office or you evaluate patients? Just raise hands. A few? How many of you use the UT classification? Does anyone use anything else? Does anyone use the Wi-Fi classification? Anyone in the room? Okay, so this is kind of why I wanted to do this lecture and talk about this topic, because when you look at patients, one of the things that has evolved over the past 40 or 50 years is our ability to understand the patients, but more importantly, our ability to understand the different elements that cause the patients to be in a limb salvage setting. And the classifications that I mentioned to you before, the Wagner or even the Fontaine or Rutherford or the UT classification, really don't assess the full disease burden of the limb. They don't accurately let us know what the physiology of the lower extremity is. And that's important for us to know or have our best assessment of in order to take care of the patients in a most appropriate fashion. Forward.
Yes.
I have no disclosures or conflicts. And one of the things that I think is good about doing lectures is you want to try to get across a couple, 2 or 3 points. And the things that I want to get across are, what are the components of the Wi-Fi classification? To understand the purpose of why the classification was created and now is being studied pretty significantly. And then how does this classification affect or improve your ability to take care of patients? And that's probably the most important thing at the end of the day. And so any relevant staging, disease staging process or system has a couple of things. One, it looks at the natural history of the disease process, which we really haven't done a good job with respect to limb salvage, specifically with respect to CLI, critical limb ischemia, or chronic limb-threatening ischemia. They're not the same thing, but we don't have a good natural history of disease process. And then the stratification should give you enough, they called it granularity in the article, but really enough detail so that you have a meaningful way to compare patients and to treat the patients. And so I mentioned these before, and certainly not disparaging remarks about these classification systems. A ton of work has been done over the past 50 years by the people that created these classification systems and others, which have allowed us to get to the point with Wi-Fi and advance our understanding and care of these patients. And so what are the deficiencies? And I already mentioned we really don't know what the natural history, or we're not as aware of the natural history of CLI or limb salvage as we are, as an example, we don't have a Framingham study in limb salvage. Framingham study was done in 1948, started in 48, and it mapped out hypertension and ischemic heart disease, and it provided a tremendous amount of information for cardiologists and internists on how to take care of these patients. We don't really have that in limb salvage, and we need that. And the second part of this is a lot of these classification systems are deficient because they don't fully assess the limb. And I already kind of mentioned that we need to try as best we can to fully assess the limb. So when you look at the Fontaine or Rutherford classification, these classification systems are primarily focused on perfusion or ischemia or vascular problem, and rightfully so. They were created by vascular surgeons and vascular people. But they don't put as much emphasis on the wound, and they don't put hardly any emphasis on infection. Okay, and as we know, infection combined with arterial insufficiency is exponentially causing the problem to get worse. So that's not an ideal classification system, just as the Infectious Disease Society of America only focuses on, primarily focuses on the infection part of it, doesn't look at the wound very much and pays very little attention to perfusion. So when we look at these, we want to take the good parts of all of them and kind of combine them together so we get a better evaluation of the physiology of the limb. And so Dr. Dave talked about critical limb ischemia, and there's just no question that patients with critical limb ischemia, poor quality of life, have increased risk of amputation. But really, from my standpoint, one of the things that we don't talk about and think enough about is the mortality rate. it's pretty significant. 5 years, it's 50 to 60%, and as Dr. Dave said, that's like a lot of cancer patients that we see. It's significant, and most mortality causes are either a coronary event or a stroke. And so when I look at these patients, and I think you have to kind of indirectly look at these patients and say, we want to save the limb, and we want to keep the limb, and we want to do everything we can to avoid limb loss and also to avoid some of the consequences that come with limb loss. Because someone that has a major amputation, below knee amputation, above knee amputation, they are at much higher risk, this patient group, because of their associated comorbidities, to have something called MACE, which is a major event, cardiac event, and could end up dying. So it's just kind of keep in the back of the mind, in your mind. And so when we look at critical limb ischemia, it's typically either ischemic rest pain or tissue loss, and it's almost always combined with some sort of abnormality with respect to hemodynamic parameters. And typically you look at your ABI, your toe pressures, or your TCPO2. And as Dr. Dave said, ABIs really aren't that valuable in this patient population because of the calcification, the false elevation. And the other thing is, ABIs, and you have to kind of keep this in your mind, ABIs look at the big pipes in the leg. We want something that looks at the small pipes. We want something that looks at the tissue perfusion, and that's what the toe pressures do and the TCPO2s do. And so one of the things that's unfortunate about the whole concept of critical limb ischemia is that there's some perception that there's a cutoff value below which you're going to lose the leg, okay? More importantly, that you're going to have poor limb outcome without vascular intervention. Now, I'm going to be the first person to tell you that I think plumbing is absolutely essential. These patients need to be revascularized, and you need to find someone to work with that can do everything possible to get the blood flow back to the limb. However, if we look at the natural history of the disease process, it gives us some insight on how to take care of some of these patients that you may not be able to restore flow to. Okay, and so we have a couple different papers that I want to just draw your attention to. This was a paper done by Marston. It's a retrospective study, unfortunately, but it's a good paper. They looked at 142 limbs, 142 patients and 169 limbs, and they looked at patients that had multidisciplinary care, meticulous wound care, but no revascularization, and all had ABIs of less than 0.7, okay? At 6 months, 25% of the patients healed. At 12 months, 52% of the patients healed, okay? So what this tells us is in some of these patients that, cannot have an arteriogram because of other medical problems or cannot undergo the procedure for some reason, patients that are recumbent and can't walk, do we need to do a below-knee amputation because we can't revascularize them? Potentially no. And so I think what this tells us is all of these patients need to be looked at individually, group assessment, and then make a decision as to whether they need to have an amputation or further wound care. And so let's go to the next article. And this is kind of like our Framingham paper. This is not as robust of a study, obviously, and it's not as longitudinally significant in length, but El-Jaziri did a paper from 1984 to 2006. And they looked at all comers with wounds and dysvascular limbs, okay? And what happened was they took these diabetic patients, you can see the toe pressures and ABIs, and they had a total of 1,151. A few dropped out. At the end of the day, 544 had vascular intervention, 602 did not, okay? And you go through this process, and what they found was 50% healed primarily with wound care and minor amputations, toes, metatarsals. 17 healed after a major amputation, and 33 died with an intact limb but an unhealed wound. Okay, so this is just something to kind of keep in the back of your mind so we have a general idea of the natural history of this disease process. Most of these patients need to be revascularized, but if you can't, I don't think that automatically commits a patient to having a major amputation. Just something to keep in the back of your mind. So once again, we go back to the classification systems that we use now, and how are we going to make these better? Well, the ideal classification system is going to take into account the history of the disease process, and it's also going to look at the entire process that affects the limb. It's going to look at the wound, it's going to look at the vascularity, and it's going to look at the infection process. And using those three things combined, it's going to give us a much better idea as to what the disease burden of the limb or the physiologic state of the extremity is. And that's going to allow us to do a better job of taking care of these patients. We're not focused just on the vascular component. We're not focused just on the infection component. We're putting this all together and assimilating all this information, and this allows us to make better decisions. So the Society for Vascular Surgery, they took the IDSA, Infectious Disease Society of America, they took their classification as the wound part, okay? And this is what the wound is. This is how they break it down, 0 through 3. And one of the things that's good about this system is it also gives you some type of expectation as to what you're going to need to do to get the wound to heal. As an example, type 1 may need a digital amputation to get this type of wound to heal. It gives you some example. And so as you go through this, you go to the ischemia part, what the ABIs are. Anything above 0.8 or a TP or a TCPO2 above 60 is considered 0. Okay, that's may not be normal, but for this subset of patients, that's as normal as they're going to get. And you go through 0 through 3, and then you go to the foot infection. And actually, this is from the IDSA. I'm sorry, I misspoke on the wound part. And they do the same thing. They go 0, 1, 2, and 3. Okay? And by doing this process, what you have is you have a wound score, you have an ischemia score, and you have a foot infection score. And what they did is the people that wrote this paper, the 12 people, got together, they reviewed the literature, and there is some subjectivity in this, obviously, but they put together a grid and applied the Wi-Fi system, and they wanted to answer 2 questions. A, at 1 year, what's the risk of amputation for the patient that's in front of me? B, will this patient benefit from revascularization? Okay, and so when you look at some clinical examples, okay, and here's an example of a patient. Ischemic rest pain, ABI 0.3, there's no wound, there's no infection. Okay, so the wound is a 0, okay? Ischemia is 3, and the foot infection is 0, so it's a 0, 3, 0, and if you go back to this grid and you put 0, 3, 0 in, essentially this patient, so go back, this patient will probably have a high benefit or expect benefit from revascularization. The risk of amputation at 1 year is low. Okay, so we go to example number 2. 55-year-old diabetic, dry gangrene, a less than 2 centimeter rim of cellulitis, okay? No pulses, ABI is falsely elevated at 1.5, toe pressure is 35. The wound in this patient's a 2, ischemia is 2, and foot infection is 1. So we go back to the grid, okay, and we apply it, and essentially you can look at these patients, you can get an idea of if the patient is going to go towards an amputation in a year, and you get an idea of if the patient would benefit from revascularization. Now, once again, I think that most of these patients need to have revascularization for a number of reasons, but this system allows us to quantify and compare apples to apples when we look at all these patients. And down the road, it will help further research and probably answer more questions than with the systems we use now. Just another example, ABI is 1.08. This patient's infected pretty significantly, stage 3, and so the Wi-Fi is 2 with respect to with respect to the wound, 0 with respect to the ischemia, but the infection's a 3. And so this patient, when you put that to the grid, this patient probably isn't going to have a significant benefit from a bypass, but probably has a significant risk of losing their limb or having some type of amputation because of the severity of the infection. Okay, so I think it's a good idea to start to think about these patients in this capacity because it's going to help you look at these patients in a different frame of mind. And I think it's more importantly probably a great communication tool, especially with your people that are doing the revascularization. And I think as you look at literature, more and more societies, groups, disciplines are moving towards utilizing this system to quantify these patients. And evidence of that is if you just look over the past, since this came out in 2014, this is a literature that's been produced to validate this system, to put these patients in stages and to assess amputation risk and benefit from revascularization. So this is a very didactic lecture, but I think it's an important concept and something that we as a profession or a group of people that take care of foot and ankle limb salvage patients need to start to investigate and start to apply to our patients. And hopefully we've gone over the components, we understand why the classification system is important, and then what effect it will have on our patient population. Thank you. Are there any questions from anybody? Anybody? Nope. Okay, without further ado, we will invite Dr. Kim. I'd like to say to the podium, but I think it's going to be via his house or workplace. Dr. Kim is a friend of mine, and unbeknownst to him, he got me involved in limb salvage. The first part of my practice, I primarily did trauma and reconstructive stuff, and through him and some of the work that he did early in his career, I got interested in limb salvage. He is a fellow alum of OCPM, which is now Kent State University College of Podiatric Medicine. He's the medical director of the William Clements Jr. University Hospital. He's the director of the wound care program. He's also a full professor in the Department of Plastic Surgery and Department of Orthopedics at UT Southwestern. So we're very fortunate to have Dr. Kim with us here today. And he's going to talk about the role of non-invasive perfusion imaging, which kind of goes well with what we've done already today. He'll be able to answer some of the questions that we've had earlier. Thank you very much, Dr. Kim.
Thank you, Jeff. Hopefully you guys can hear me. Yes? Hello?
Yes, we can hear you great.
Okay, great. Thank you. Thank you for the invitation. I appreciate it. And I'm so happy to see that there are actually live meetings going on. In this time of the COVID-19, it's really changed the dynamics of medical education. I'm just sharing my screen right now. I'm going to talk about the role of non-invasive perfusion imaging. I work very closely with one of my partners. My first recruit at UT Southwestern was a vascular surgeon I had been working with at Georgetown before I made my move, because I just understand that the vascular component is so critically important to what we do. Just as financial disclosures, I have nothing relevant to this lecture. When I think about assessing perfusion, it's like climbing a ladder. And in the plastics world, there's something called the soft tissue reconstruction ladder. I think in the vascular assessment world, I think there's a similar concept. The first thing you want to look at is tissue quality, perhaps palpation of pulses, Dopplers, segmental pressures, TCOMs, and skin perfusion pressures, and hyperspectral imaging, fluorescence imaging, contrast angio, and I call it the Elysian fields, because I'm not sure now in this time of the technology that we have, if we can skip some of these. I will tell you, I'm always very in favor of contrast angio, even as a diagnostic measure, because I think it gives us some roadmap. And the way that I explain it to the trainees is the angio will provide the major highways and major streets, but then you need to get into your neighborhood. And that neighborhood are the smaller vessels that directly feed the tissue. And this is where you look at skin perfusion, for example. This is a paper that we published several years ago, just a very simple algorithm as to how to assess the perfusion to an extremity, for example. And essentially, you've done all of these things probably without even thinking about it. But let's go through each of these things. One of the tables that we put in there are some benefits and limitations. Obviously, there are limitations to some of these modalities, including there was a large push in the 90s and the early 2000s for TCOMs, and it's still used for HBO purposes, and perhaps you use these in your clinic as well. But we know that there are some major limitations to TCOMs, including it's very operator dependent and it's influenced by edema, infection, other issues that may not give you an accurate measure. With the development of some technologies that have evolved, and I'm going to focus in on hyperspectral imaging and non-invasive fluorescence imaging in just a few minutes. We published a couple of papers on those topics. It may provide some higher utility. But I will tell you, in general, when I look at any kind of assessment tool, you have to first look at the reliability, validity, and utility of those things. Reliability is the numbers, the results stable and consistent. The validity is it measures what it's supposed to measure. And the utility, is it useful? Is it logistically pragmatic? If it's not useful, meaning that you have no access to it or it's hard to use, then it's probably not going to be utilized in wide fashion. So from the very bottom of that ladder, the first important issue that you should, or quick assessment, is just the tissue quality. And when you look at tissues like this, it's fairly obvious. And there are less obvious examples like these cases here, where you're not exactly sure how much perfusion is getting to that area. So when we look at just inspection, and you look at the utility and validity of just inspection, there are lower scores correlated with more severe organ dysfunction. And I think for our patients with multiple comorbidities, they all sort of lie in this category. And we look at palpation of pulses. I think this is very interesting. You know, we are often fooled by palpating pulses, assuming that there's good blood flow, and there's actually not by other measures. But if you look at the kappa coefficient, which is just the reliability of this over time, an agreement between people, you can see in the vascular lab, they have a higher kappa coefficient than even vascular surgeons do. I thought that was a very interesting study that was published. Here's another study that was published looking at palpation of the femoral and popliteal artery. And if you look at the surgeons, and this is often what I see in some surgeons anyway, they go right to the popliteal and they listen or they feel for a pulse, but the kappa coefficient is 0.5, which is not very good. The higher the kappa coefficient, the higher the reliability is. Now let's look at Doppler exams, and I don't want to belabor this, but Dopplers I think can be helpful because the utility is pretty high. The problem with Doppler exams is that sometimes it's hard to differentiate between, for example, a monophasic versus biphasic versus triphasic signals. So it can give you a really quick and dirty look at this, but it's not always reliable. So again, you look at you listen for the signal, or you can get a tracing as well that may be helpful. When I did a lit search on the reliability, validity, or utility of this method, which is commonly used everywhere, I didn't find any studies that actually looked at the reliability of using a Doppler exam. Let's move on to segmental pressures. If you look at the reliability of segmental pressures, it's very, very low. And this is a large study of 108 patients. That the intra-observer reliability, that's what that means is if I took an exam, did the segmental pressure exam and did it again sometime in a couple days later, the reliability is less than 8%. And then between observers, it was about 9%. So it's really poor reliability. Here's another example looking at intra-observer reliability within the same person. Here, vascular lab techs versus less experienced general practitioners. And you can see the reliability with experienced technicians was 7.3%, which is extremely low again. And less experienced reliability actually was higher than that of more experienced individuals. The comparison of measured values versus automated cuff versus probe, significantly higher values utilizing an automated system versus a manual system. Let's move on to skin perfusion pressures. If you look at the reliability and validity of these skin perfusion pressures, you can see here the reliability is pretty good against ABIs and pretty poor versus TCOMs. And I don't want to belabor this. I know that SPPs are not widely used anymore. We have a device that is not even being serviced anymore in our wound program. I think the company actually went out of business. So let's go to TCOMs, which is probably the one that people talk about in the academic world a lot because it gives you a value. It does not mean that it has high validity, however. The positive predictive value of TCOMs was about 79%, which is not perfect. So let's move on to some of these more novel technologies that have been evolving, including hyperspectral imaging, which actually has been around for quite a while. And essentially what it does is gives you a value of oxygenated and deoxygenated hemoglobin to the area of the wound, for example. So what is the predictive value of this? When I started looking into this, there was a paucity of evidence actually looking at hyperspectral imaging. Although if you look at it, it's kind of cool to look at the spectrum of color of oxygenated, deoxygenated tissue. But what I wanted to do was to see what the baselines of these are in non-ulcerated patients. So we did a study comparing non-diabetics versus diabetic patients and seeing if there's a difference in hyperspectral imaging values that we got. The other thing that I wanted to use, there's actually more than 2 devices currently on the market that can assess the hyperspectral for hyperspectral imaging. However, we chose the top 2, the ones that were used more frequently, talking to our colleagues and looking at the literature, and we compared those side to side as well. So here are our findings. I think it's important to understand pathology by looking at people that don't have pathology, for example. So here is a table in our paper looking at diabetics versus non-diabetics, looking at just the oxygenated hemoglobin on the left and just the deoxygenated hemoglobin on the right. And this is device A. This is one of those 2 devices that we tested. And what was really interesting was there was some consistency, and you can see it's not 100% oxygenation to the tissue, which is what we would expect. But they were very similar between the diabetics and non-diabetics. And even more importantly, on the third metatarsal joint, that was the lowest level of oxygenated tissue that you see here. That's the R3D number in the various areas of the foot. Now, if you break that down, those were the mean values of oxygenated tissue. If you look at the standard deviations, I think this tells you a lot, because if you look at the ranges, this sort of breaks down those mean values and provides ranges. You can see there's a huge range of values for these. And if you look at the standard deviation bars, they all sort of overlap, even though the mean number of the R3D that I just mentioned earlier was lower than the other areas of the foot. However, it seems to wash out in the end if you look across all the standard deviation bars cross. So to me, it's not that clear. This is device B. This is the second device that we tested, and you can see very similar patterns as we saw in device A. So both, despite what the devices, the technology is different as reported by the manufacturers. But if you look at the results, they're pretty similar. One consistency that we found in these mean oxygenated hemoglobin values, again, in the R3D region was lower. The mean values were lower in diabetics and non-diabetics, but comparable to each other. But then again, if you look at the standard deviations of these, they're pretty, first of all, it's a widespread, which tells me it's not necessarily very precise. And also the standard deviation bars tend to cross each other. So again, may have some limited value. Let's move on to non-invasive fluorescence imaging. And this is something that people have been interested in, not only in the lower extremity space, but all over the body. And as you know, this became very popular in the early 2010 to 2015 period. And essentially what it is, I'll play, and you guys know what this is, and I don't want to use brand names here, but this is the SPY device, and you guys have probably heard that. You can see this blush that happens with the injection of indocyanine green. And you can see this is the right foot, dorsal foot, second toe amputation site. You can see the blush to perhaps indicate the degree of perfusion. But there's some problems with this device, and I'm going to show you one of the problems with it. It's hard to assess blush because it's driven by lots of different factors, including their cardiac output, their blood pressure. There's lots of things that cause a lot of noise in reading, at least visually reading out the output of this indocyanine green non-invasive angiography. So one of the people that pioneered this area of technology started looking at the slope of the curve, because you will see the slope, and you can see it on the bottom, so how I broke it down. That first part is the initial indocyanine green getting to that tissue, and then the arterial flow is the ingress, if you will, and then the egress portion is the venous output of the dye itself. So let's take a case example. This is a patient has a right dorsal foot abscess, and there was about 30 cc's of purulence drained at bedside. And if you look at the ABIs, It's 0.61 on the, I think that's the right, and 0.69 on the left. And I think we'd all agree there's some compromise to the tissue there. And I'm just going to run this, and I'm going to speed it up a little bit, and you can see that initial blush happens there, and that's presumably arterial flow. And you can see how bright it goes and the intensity of the blush. We're going to talk about that in just a minute as well. And then as that dye sort of goes out the venous system, it starts to decrease in intensity or blush. So if you were to map this, and what you can do is you can quantify is percent blush. And this is interesting because it's when you look at these numbers, you say 106%, how's that possible? And that's a really good question, because one of the limitations of this device is you have to put a marker on the place where you think it has the maximal amount of perfusion, or the device can do that itself. And then these percentage values are relative values to the area of maximal perfusion, or is detected maximal perfusion. And here's another example, just to talk this through here. The left distal SFA stent was placed, and the wound turned wet, and then we got an angiogram. You can see there is not much good flow in there into the foot. The posterior tib is completely occluded, and it's a collateral, what it looks like the anterior tib that's feeding toward the bottom of the foot. And the anterior tib is sort of a squiggly, some collateralization as well in the leg, but no really great inline flow to the foot. So let's look at the SPY image of this patient. And I'm just going to, again, speed this up. You can see that initial blush, and you can see that big toe, that hallux has no blush. And this seems to be pretty obvious that the perfusion is lacking in the area. Why it may be clinically important to us is to say, well, what level should we do, for example, a first ray resection where the tissue is viable enough? So you can draw on a marker that line of dark black, you can see it here, that does not have enough perfusion. And as we go forward through the timeline, you can now see some venous flow here, the outflow of the indocyanine green. And if you again if you want to quantify this, you can see that at the level of the big toe, you can see the relative perfusion is 8.6%. This is the 100% marker up here that we applied here based on the angiogram, because you did see some anterior tibial flow, and that's the area of maximal flow. So that's your relative point of value. So we removed the area that we thought was not perfused well, and you can see how it can dictate your clinical plan, or potentially. So one of the other questions that we asked, that we published this paper looking at a non-invasive angiography and seeing if we could create some baseline values, because people talk a lot about pathology and say, look, this is abnormal. And my question is, how do you know it's abnormal? Just looking at your whatever tool that you use to assess the tissue. So like the hyperspectral imaging study that I showed you earlier, we just asked a simple study. Let's look at normal patients with patent 3-vessel runoff to the foot, and look at their non-invasive angiography numbers to see if we can see any patterns. Again, just as a point of reference, remember that initial time to blush, you can see that where it starts to peak, and then the ingress and egress values. And this is the area of interest, if you will, of the foot that you're interested in. So we did that. So we looked at these values, and we looked at both the dorsal and plantar aspects, and you can see time to blush, that initial time to blush, the brightest region that we marked out as well, and then the egress portion as well, as the dye goes back and is eliminated. One of the interesting findings here we can see is on the plantar aspects, the time to blush was much faster than the dorsal aspect, which is, these are again patent patients with no peripheral vascular disease. And that makes sense, because the posterior tibial artery is a more straight inline flow than the dorsal aspect to the dorsal aspect of the foot. But this provides some good baseline values for us as we look at abnormal values in our patients. Now, just as a practical consideration, now looking at, again, that ladder, the perfusion assessment ladder, you can see, and these are just this is my view of these methods. And again, I'm probably very biased by looking at these, but if you look at the reliability, validity, and utility, there's really no single method that provides you high levels of all three of these. There is a little give and take to each of these methods. Now, we're doing more work here at UT Southwestern looking at hyperspectral imaging. I think the utility of that is extremely high. Now, the validity of that and reliability of that, we still need to sort of figure out, but it may be the future for these patients because there are no other, there's very few limitations really, right? You just take a picture of it versus having to put an IV in and pushing dye and so on and so forth. So the risk to the patient is very low. So in conclusion, I think all patients must have a vascular exam, even if the limb looks perfused. And again, looking across the literature, as I did for you guys just a few minutes ago, you need to assess for yourself what's the level of reliability, utility, and validity of these tests. The other part is arterial disease is progressive, so you need to repeat these tests over time. You know, it's interesting when I see new patients, they say, oh yeah, I had a vascular exam, I had an ABI or whatever, I had it 6 months ago. I'm like, well, your vessels are probably more diseased now than they were back then. We need to reassess you. Like all clinical decisions, the entire body of perfusion assessment should be taken into account. It's just like I'm going to talk about in just a few hours. I think I'm giving a lecture on cultures and what they mean and the confusion around cultures. And I will tell you that you have to use a Gestalt approach to looking at anything. You can't use a single method of assessment to determine your treatment plan or make any predictions on healing. I think you need to look at all of it. And then you have to go with, it's so weird to say this, but you have to sort of go with your gut. What does your gut tell you as far as the degree of perfusion to the area? The predictive value is related to ultimate clinical outcome for any of these diagnostic modalities is questionable. Now, so I presented all this literature about validity, utility. None of that matters unless you can tie it back to the patient and their clinical outcomes. So I think that's the biggest question that we have to answer to all of these is how predictive they are to not only one, saving the limb, but healing a wound, for example, if you're dealing with just a chronic wound. Thank you. Any questions?
Does anybody have any questions? I have a question for you, Paul. Thanks for the lecture, by the way. So you have a patient, what is your ideal approach to look at tissue perfusion? What do you do?
Yeah, so I guess I'm sort of old school. You know, we do have 2 hyperspectral imaging devices in our clinic, but honestly, my first go-to is I look, and when I teach trainees, I said, look at the foot. Does it look like it's not perfused well? And there are some classic signs of that. Not only shiny skin, but I look for hair growth. That's a really, really easy one to teach. Then I go to Dopplers, and then I have the privilege of working with a vascular surgeon who really, Michael Sia, who's really committed to lower extremity. And so he and I bring him in constantly, especially if I'm doing some sort of surgery. I'll request an angiogram, whether it doesn't look like it's needed. I think a diagnostic angiogram has a lot more benefits than disadvantages. For me, for tissue closure, it's really important for me to sort of map out the degree of perfusion to the limb.
Thank you. Does it go? Yes.
My question is, as a podiatrist, we do routine foot exams, and often I'll see a patient where I can palpate their pulses. Sometimes I can only feel the pulses with a Doppler, but they don't have a wound. Do you think it's our job at that point to order these arterial studies?
You know, that's a great question. I'll tell you, I work with Cam Akbari, who's at Georgetown, as a vascular surgeon, very gifted vascular surgeon. He never intervened, and I'm going to answer your question indirectly. He never vascularly intervened if the wound was healing. Even if there was a wound, he never intervened if it was healing. If it stopped healing, that's when he intervened, because his philosophy was, and I agree with this, he can do some damage by doing a non-invasive assessment or intervention. So why do that if you don't have to? Now, if you're carefully diligent in monitoring these patients, and if you have a suspicion that there is ischemia, I think you do some non-invasive vascular testing. I don't think it has to raise the level of an angiogram for every patient.
Thank you.
Any other questions? Okay, for our final speaker for the early morning session, we'd like to invite Dr. Alan Jacobs. Is he there? Well, I'll go ahead and introduce him. Dr. Jacobs graduated from PCPM back in the 70s. Dr. Jacobs is one of the elder statesmen and one of really kind of the grandfather of podiatry. He's one of our best academicians, and on a personal level, he has taught me an immense amount about foot and ankle problems as well as just about practicing medicine. And so I teach residents and I tell them, anytime you see certain people lecturing or you see certain people that have written papers that you know are good, that's where you want to get your information. So I always like to listen to Dr. Jacobs because I always learn something from his talks. Without further ado, hopefully Dr. Jacobs is there. Are you there, Dr. Jacobs?
Can you hear me?
Yes, we can.
Oh, wonderful. I thought for sure I'd mess that up. Okay, well, good morning, and it's been in my opinion, an excellent program thus far. Wish we had a little bit of time for more panel discussion, but maybe we'll do that at another time. Now, it's interesting, I just read that podiatry accounts for 1% of the money spent by Medicare. So obviously, we are seeing a lot of elderly patients, and all of us have been taught from day one that with aging comes increased incidence of vascular disease. We also know, starting with the partner study, that patients with peripheral vascular disease are at increased risk for cardiovascular disease, cerebrovascular disease, and the converse is also true, that we see many patients that have diagnosed cardiovascular disease or other diagnoses with which we know increased risk of peripheral arterial disease is associated: obesity, hypertension, history of smoking, and so forth. So while it is true that we see some patients that have just coronary artery disease or cerebral vascular disease or peripheral arterial disease, in the majority of these patients, there's a tremendous overlap. And there's a society that's been around for a number of years in podiatry called Save a Limb, Save a Life. And the partner study showed, and I was one of the clinical researchers in that study, that you can take patients with reduced ABIs and demonstrate that in hindsight, these patients had undiagnosed coronary artery disease, cerebral vascular disease, and indeed not only save a limb but save a life. As has been discussed already, we know that patients that have claudication or patients that have critical limb ischemia, however it is you define critical limb ischemia, and Jeff has talked about the very definitions of that, they have reduced survival rates, and they also have reduced lifetimes without some significant event occurring: stroke, heart attack, loss of limb, and so forth. So looking at the geriatric patient, we know that the majority of amputations in the United States are in the geriatric patient. Diabetes has become a major contributing factor. You've already heard that once above knee or below the knee amputation occurs, we have reduced survival rates. Part of that's due to the fact that probably patients that require major amputation are sicker patients and likely have more comorbid conditions. But we also know that patients trying to ambulate with a major amputation have greater strain on cardiovascular system. And as a result, we see significant increased morbidity and mortality in patients that undergo major amputation. Now, what has been the big game changer in my career, and I started in 1973, has been the availability of endovascular interventions of various types. Prior to that, our only option was either amputation or referral of the patient for major bypass surgeries. And as you all know, the problem with that is we're taking sicker, older people, subjecting them to hours of anesthesia, major dissection, significant complication rate. And now we're able to offer limb salvage to our older patients with multiple comorbid conditions with basically a trip to the cath lab. The other thing I've seen in my 40 plus years of practice that has changed tremendously is the interaction of podiatry with both vascular surgery and cardiology. If you look at programs like C3 and other similar programs, I remember a time when there was absolutely no podiatry input. And now you have cardiologists and vascular surgeons learning from podiatry and vice versa. So we become more aware as people like Dr. Dave say, look, here's the options available should you refer these patients. We've also learned about functional foot amputation. I wish we had time to talk a little bit about the enthusiasm for surgical intervention. And I'm going to speak about that later, but I just want to make a point. All of you probably need to think about this. As we start doing surgery to relieve pressure, and this has already been alluded to in prior discussions and questions to Dr. Steinberg by Jeff, we have this transfer metatarsalgia issue, transfer of weight to other parts of the foot, and we know that certain amputations, such as hallux amputations, first ray amputations, are associated with a very high risk of complication. So we've kind of come to learn to take a more global view of this, and personally I think that amputations like the transmetatarsal amputation, although not perfect, definitely have a greater predictable outcome in the long term. So we know that arterial disease in our older patients is common. The majority are asymptomatic, and this is important because we as podiatrists are seeing a lot of geriatric patients. As I mentioned, 1 out of every $100 that Medicare spends goes to a podiatrist. Atypical symptoms are common. Jeff made mention of the Rutherford classification and Fontaine classification. These things are based on the assumption that that patient is walking enough to give us signs or symptoms such as claudication. But in fact, less than 1/3 of patients that have significant arterial disease who are geriatric patients have significant classic symptoms of claudication. And it's up to us to look for these patients. Now, Paul Kim said something that was told to me by a vascular surgeon when I first started practice. And he said, when all is said and done, it's your clinical impression that ultimately makes the biggest difference. So we could argue about the validity of various invasive or non-invasive studies for looking at vascular perfusion, but the end line is, as you go along in years, you develop a sense for what is significant and what is not. And we're also seeing increasing liability, meaning lawsuits, for a failure to diagnose. So Jeff, in talking about the Wi-Fi classification system, mentioned, for example, the Rutherford classification. And this is a classification system that in part is based on symptomatic claudication. But many of our older patients don't walk enough to claudicate. They don't walk far enough or fast enough to claudicate. And again, they have atypical symptoms. And, a common differential that I see, I'm sure you do too, are patients, for example, that have venous claudication, or they have a spinal stenosis with pseudoclaudication, or they have pain from arthritis in their hips or knees and so forth. So we have to search out these patients because frequently they are atypical in presentation. And the other thing that has impacted us are diabetic patients. I seldom saw a diabetic patient in my office when I first started practice, and we know that diabetes is a big part of our practices. It is a big part of podiatry. We have tremendous integration between podiatry and the American Diabetes Association, and the average podiatry practice has about 300 diabetic patients, and so we have to be more alert. But we still see a high amputation rate, as Dr. Dave mentioned, and why is that? That's because primary care physicians, while they do wonderful things in other areas, perhaps are not as good at detecting peripheral arterial disease. And so frequently there's a delay in diagnosis, a delay in referral, or, as has been mentioned, inadequate evaluation, inadequate treatment. The other thing that's come up legally, and I'm not suggesting this is the only reason you should be looking harder for arterial disease in our elderly patients, is how we qualify patients for preventive care. You know, we have lots of podiatrists going to senior care facilities, extended care facilities in our offices, and we receive payment from Medicare based on the existence of signs and symptoms of vascular disease. And yet we do nothing about it. And a percentage of these patients do go poorly. And then the question is, well, doctor, you've been charging Medicare to render preventive care because you're saying this patient's vascular supply was so poor, it would be dangerous for them to even cut their own toenails or trim their own calluses, and yet you did nothing to evaluate that vascular disease, and now our patient has lost their leg or become septic or lost their life. So it's something to think about every time you say this patient has significant vascular disease, but I'm not going to do anything about it. Jeff Robbins showed, for example, that in our diabetic patients, even simple problems like fungal toenails are associated with a much higher risk of gangrene and foot ulceration. There's lots and lots of studies like this. This one happens to be from the Seattle VA hospital, but the same idea. And that's that again, simple problems in the presence of vascular disease end up with disasters because of the complications of that. Even problems like tinea pedis in the presence of arterial disease, together with the other factors in our diabetic patients, result in significant morbidity. We also have confounding factors in our older patients that are listed here, and this makes differential diagnosis at times much more difficult. It's ironic that people complain about Medicare paying poorly for care of our patients, and yet if you think about it, the Medicare patients actually take the most time to evaluate. They have longer medical histories, they're taking more drugs, they have more comorbid conditions, and it takes a long time to sort it out. Paul Kim mentioned looking at the foot, and in terms of, say, common ulcers such as hallux interphalangeal joint ulcers, there's a difference between the appearance of a classic, say, neuropathic ulcer and a neuroischemic ulcer, and with aging, with more comorbidities, we get more of an ischemic contribution to this. We've also learned that our older patients that have venous ulcers very frequently have concurrent arterial disease. And it's no longer a matter of saying, is this a venous or ulcer? Is this a neuropathic ulcer? Is this an arterial ulcer? Because many times these patients actually have a morphing of more than one factor. So that oftentimes in treating venous ulceration, interventions for arterial disease are appropriate. There's been some discussion already about how you evaluate these patients. I think still it's low technology, high touch. I do Doppler evaluations on these patients, and if they're monophasic, then we go ahead, or if they have signs and symptoms of vascular, we go ahead and educate the patient. We encourage exercise programs, and then we refer for more formalized studies, and if those studies are significant for the presence of disease, we refer them off to interventional cardiology. We also talk to the patients about associated risk factors, and while it's true that we may not be the ones treating their systemic disease, we sit down and talk to them about smoking, talk to them about weight loss, talk to them about their dyslipidemia, and educate these patients, and of course, always referral. The Society of Vascular Surgeons makes these recommendations, and I think it's something to think about. You want to refer for any non-healing wound, for any signs or symptoms suggestive of vascular disease, generally anybody over the age of 65 or patients over the age of 50 that have comorbid conditions with which we know vascular disease is associated. Now, what happens to these patients obviously becomes the decision of interventional cardiology or vascular surgery, and they're going to look at these patients to make those incisions. So in summary, when it comes to the older patient, we are seeing a great deal of geriatric patients in our practices, and we have an increasing aging population. And with that comes diabetes. With that comes increasing risk of peripheral arterial disease. And I think we need to be the screening people for this. So over the age of 65, I think at a minimum, you want to do appropriate screening. Not all of us are university-based and have access to more sophisticated, if you will, testing. While these things are nice, they're just not practical. And I think you want to refer to the eye test, at least do Doppler studies, refer when appropriate, spend the time educating patients, perform a reevaluation on an annual basis. And I think a lot of this, frankly, including wound management, can be performed at the office level. So I thank you for the opportunity of addressing this subject.
Thank you, Dr. Jacobs. Are there any questions from the audience? Anybody? Panel? Yes, sir.
Yeah, Dr. Jacobs, I thought that was an excellent example of how to do the baseline studies. Do you find that in our suspected PAD, like our diabetic patients, that you refer out for continued baseline studies on these patients that you said are, you know, we have a lot of them that are not active enough, they're not walking, so they don't really become symptomatic. So in that case, are you still looking at trying to maintain a baseline for these patients?
Again, what I do is I do a Doppler evaluation, handheld Doppler, but I do have printing Dopplers too. But if I have suspicion of any kind of significant vascular disease, I send them out for formalized studies. If those studies come back with lower ankle pressures, monophasic waveforms, and so forth, I always send them out. The geriatric patients, I have to admit, my overwhelming prejudice is for interventional cardiology because they have the most to offer my elderly patients because of their comorbidities. So that's, and I'm not saying it's right or wrong, but that's my routine. And again, I just want to point out that I'm seeing more and more litigation, even in patients or doctors that are working for these companies that just send you out to do sort of basic podiatry care in old age homes, where patients who are even non-ambulatory end up with lost legs or end up septic and dying. And then the question becomes, well, you qualified this patient for care based on their risk factors, and yet you did nothing about the risk factors. And we're seeing more and more, you know, geriatric patients like myself in the office now. It's not something that's going away. Diabetes is not likely to go away in the short term. And I think we have to take a more serious look at evaluating our geriatric patients before these problems arise.
Any other questions? Dr. Jacobs, could you go right? I don't want to belabor this, but I think it's important. So you have your group of patients that you see 3 or 4 times a year, and do you take those patients and once a year kind of do an overview of their risk factors? And for those patients that either have a change in those risk factors or you identify new ones, what's the process then for you? What do you do with those people?
I, like most podiatrists, do an annual comprehensive diabetic foot examination or reevaluation, particularly if they've had another intervention. Because if you think about it, you know, the interventional cardiologists, they're in that cath lab for hours at a time doing these procedures. They have limited office hours, and we're seeing these patients at least 4 times a year. So I monitor them, and I'll talk about that later, for any changes in their status. And absolutely, if I think there's something of concern, I'll either repeat the studies or send them out for another opinion. Because, you know, a lot of them do well with simple measures like Playtal or Plavix or increased exercise, weight loss, dietary improvement, cholesterol lowering agents, that type of thing. So not everybody needs some type of intervention that's invasive, but these patients do need to be watched carefully because it goes with aging, and it's one of the things we're supposed to do. And podiatrists are in the best position to do it because we see these patients multiple times a year, and we have sort of the whole package. We're like the quarterback on a team. I was going to say Carson Wentz, but if we're from Philadelphia right now, he's not a hot ticket. But I mean, we're the ones deciding who gets the ball, what kind of play is going to be run. And I think we are in the perfect position because we have a little bit of derm knowledge, biomechanics, vascular, neurologic. So we're kind of the general practitioner of that lower extremity. So yeah, annual evaluation is, I think, very important.
Any other questions? Thank you very much, Dr. Jacobs. We're going to go ahead and have our break, and we'll start back here at 10:45. Thank you. Okay. It is 10:45, and in the interest of staying on time, I'm going to ask everyone to come back in and take your seats, and we're going to proceed with the next lecture, which is Dr. Paul Kim, and he's going to talk about cultures. Dr. Kim, are you there?
Yep. Thank you. Thank you, Jeff.
Thank you.
All right. So I think, this is a larger talk that I give, and I know due to the time limitations, I can't get into too much depth. But, when you think about cultures, it on the face of it, it seems like it's pretty straightforward. But honestly, I don't have many answers for you all. There's a lot more myth than fact in this space, and the more I learn about it, the more confused I get. So I'm going to try to be as least confusing as possible, but please forgive me if I don't have all the answers. Just as my disclosures, I don't have any financial disclosures for this lecture, but I am totally biased in my approach. And the more I learn about bacteria, and especially in this time and space in our world, I think the more confused I become. So let's start with the case study. This is a patient that was a consult from the hospital service for possible osteomyelitis of the heel. And you can see there's some erythema, a small eschar there, probably a wound at some point. And the white count was 17. The blood cultures were taken, which showed no growth. The sputum culture is moderate MRSA. Sorry, I'm trying to navigate this thing. Okay. And so we ordered x-rays, and doesn't appear to be any fracturing or cortical erosion on the AP and lateral views. The radiology report reported no evidence of osteomyelitis. The MRI was ordered by the medicine service. You can see here on these two cuts, there's some increased signal intensity through the calcaneus, the talus, and the distal tibia, also the cuboid as well. And so we were reconsulted because essentially we had signed off and said there's no evidence of bone infection. And then they ordered the MRI, and the radiologist reported suspicious of osteomyelitis and multiple abscesses. And so let's talk about the diagnostic reliability of these kinds of tests. So the patient was taken subsequently to the OR for bone path cultures and exploration. I didn't really see much in there. Some superficial fatty necrosis was present. We took some deep bone cultures, showed no growth. We took some deep swab culture, showed no growth. And we took some bone biopsies that showed necrosis, inflammation, suggestive osteomyelitis. So is this osteomyelitis is the question. And just by the way, when you send a path specimen, be careful with that, because the definition from a pathologist of osteomyelitis is not a clinical definition. It's a definition that suggests inflammation, does not necessarily suggest infection. So be careful with that one. But ultimately, what was found was this patient had multiple infarcts of undetermined etiology. So this was more of a vascular issue than an infectious issue. Whenever I'm faced with seeing a patient, this was discussed this morning, and I sort of distilled it down to an equation. When I see a patient for the first time, I think about their healing potential. And this equation is something that I came up with. In the numerator, there's a 1, denominator, there's bacteria, perfusion, and tissue mechanics, which is what we're talking about in this lecture, which is bacteria. But I think the driving factor for healing potential is the host. That host is to some exponential that I don't know and don't understand. It could be their comorbidity profile, it could be their genomic profile, it could be their access to healthcare. It could be a lot of different things. And I think that really drives the healing of a patient. This is an idealized treatment algorithm for the inpatient care of an infected wound. Upon admission, within the first 24 to 48 hours, if there's a high suspicion of infection, I think that it at least deserves an exploration in the OR, where cultures are taken before and after you debride and irrigate. And then you plan for closure or coverage prior to discharge. And I'm going to focus on detection of bacteria. And there's a series of papers that we published looking at detection of bacteria. This is a clinic-based study where we wanted to understand if there was reliability from the swab cultures that we often take of fluid in the clinic and compare that to semi-quantitative cultures. These are colony-forming units of bacteria that you guys are probably aware of, and a new technology which uses fluorescence imaging where essentially a laser shine that vibrates the bacteria and they fluoresce. And so we wanted to know if there was a change in bacterial amount based on whether you excisionally debrided in the clinic or not. And it turns out, first of all, that there was no difference between pre and post debridement culture results on all three methods. So, it sort of begs the question, why do we debride as frequently as we do? The other part of this is that we looked at the differences in the three different methods, and they were very consistent as far as detection of amount of bacteria. When you think about semi-quantitative cultures, which is the classic agar culturing technique, it's pretty not quantifiable. Essentially, what you're doing is you're getting scant, moderate, heavy, no growth. That doesn't really help us very much as far as clinical treatment of these patients. And many of you don't have access to colony-forming units of bacteria, which gives you a more quantifiable per gram of tissue amount of bacteria in the area. And again, there was consistency throughout these three diagnostic methods, but no real change in the amount of bacteria based on debriding the wound. Another study that we published looking at the reliability of bone pathology results versus that of culturing of bone. And there was only agreement about 41% of the time. This is sort of a heat map on the right of bone pathology reading of osteomyelitis or bone infection versus that of cultured bacteria. So it makes you sort of question both methods, not just bone pathology, not just cultures, as far as trying to detect infection in bone. And you look at outcomes, and that's really what we should be interested in as clinicians, is to make a difference in outcomes as far as bacteria is concerned. And this is the classic agar culturing method that we use for this study. We found there was no difference in 30-day outcomes based on positive cultures at the time of closure or coverage, because typically what you want to see is that the infection has resolved. And often you use many different methods, and culturing is one of those that we use to say, look, there's no growth or scant growth where they started with heavy growth, and therefore we can move on to closing or covering the wound. What we found was there was really no difference at 30 days if the culture came back positive at the time of closure or coverage. Here's another paper that we published at Georgetown where we looked at the effect of positive post-debridement cultures. These are supposedly clean cultures after you've removed all the non-viable infected material on local muscle flap reconstruction in lower extremity. And we did find that there was positive post-debridement cultures significantly increase the odds of non-closure, but did not impact overall flap survivability, which is interesting because as you all know who work with plastic surgeons where they do local muscle flaps, they often dehiss in certain areas, and that's just sort of managed very conservatively in the clinic, so it's not a big deal. What is a big deal is flap survival. As did you just kill the muscle by moving it, kill the tissue by moving it? And it didn't seem that even if you had positive cultures at the time of these local flaps, it did not impact flap survival at all. The next study that we looked at were risk factors associated with major lower extremity amputation after osteosarcode diabetic reconstruction. And what we found was the preoperative soft tissue bone infection was not a major factor in amputation. So even if they had a positive culture, it did not necessarily relate to a outcome of major amputation. So it wasn't a major driving factor in whether a major lower extremity amputation was elected to be performed. The next study was a sort of a treatment study. This is a part of a prospective RCT that we did comparing normal saline with an antiseptic solution, which was very well studied at the time and still continue to be studied. It's PHMB, which is polyhexanide with betaine. Polyhexanide is a very potent antiseptic with 10 minutes of contact time, essentially eradicating aerobic, anaerobic, fungal, yeast, mold, all of those pathogens. And we compared it directly head-to-head with normal saline. This is using an installation device, by the way, that dwells solution over a period of time. And what we found was that as far as some of these surrogate outcomes that we were interested in, including the number of operations prior to final surgical closure coverage, length of hospitalization, all those factors, there was no difference between this potent antiseptic versus normal saline, which really has no antiseptic properties to it. So again, begs the question, do we need to impact the bacteria as much as we once thought? Here's another study that we looked at periprosthetic defects in patients with total knee arthroplasty and the functional outcomes. And part of that, we looked at the number of debridements that were necessary. Remember, in the classic model or idealized model, you want to try to get to a culture that's negative results, meaning there's scant or no growth. But in this study, when we looked at the periprosthetic in total knee implants, essentially, the number of debridement prior to definitive closure did not impact limb salvage rates. Some of these patients still went on to amputation regardless of negative cultures. The next study that we published was looking at hardware or trying to retain hardware. As you all know that, if there's skeletal, you want to maintain skeletal integrity. So if you can maintain the hardware that was in there in the environment of infection, that's always a plus. Instead of having to remove hardware, whether it's a total joint or screws and plates, you want to try to maintain that skeletal integrity as much as you possibly can. But sometimes you have to remove it because it's infected or colonized, or people talk about biofilm. That's a completely different lecture that I think is more controversial than people make it out to be. But what we found is that positive cultures in this case for microsurgical free tissue transfers resulted in higher hardware removal if their cultures were positive. Ultimately, I think it's about the host, as I talked about. This is looking at a paper that we published looking at the number of comorbidities and salvage rates. It is very clear the higher number of comorbidities the patient had, the higher likelihood of hardware removal. And again, it may not be a consequence of the bacteria, but the host underlying that infection that may be driving salvage rates. And just as an aside, this is a paper we published again when I was at Georgetown looking at how sick our patients were. And our average ASA, which is the American Society of Anesthesiologists classification, this is how they rank the risk of anesthesia for patients that go to the OR. And we looked at the average ASA across our patients, over 233 patients, and the average ASA was 3.5. And it's pretty startling if you think about that, because a 3.5 is defined as severe to extreme systemic disorder. So these are patients that are very, very sick. And again, I think this goes to the story of the host driving a positive or negative outcome, because if you're dealing with patients that are really sick, regardless of the kind or the amount of bacteria that may or may not be present in the area, may be the driving factor. I think there are lots of remaining questions. These are just some of the few questions that I have that's still sort of lingering. Do our diagnostic methods provide meaningful clinical outcome? Because honestly, the agar culturing, the classic Levine technique, is over 100 years old, where we encourage the growth of some bacteria and inhibit the growth of others. So we're not even sure if when you get a sensitivity profile after you get a culture swab, whether those are actually the offending bacteria that's causing the problem. And again, I just want to talk just quickly about biofilm. There's been a lot made of biofilm. I still don't think we understand it fully. I think there's good biofilm and there's bad biofilm. The true impact of biofilm and clinical outcomes is still a question mark in my mind, and whether we really need to treat it or we don't. And we can't treat it through the classic methods if you do elect to treat it, because the mechanism of action, the metabolic rates of these biofilm are so low that the traditional mechanisms of action antibiotics are completely ineffective against biofilm. And perhaps it's contributing to wound chronicity, but in the acute care environment of a planktonic or a acute infection, I'm not sure we're impacting them at all, and whether we should or shouldn't be looking for these. And trying to detect biofilm is impossible. You can't see them just through your eyes. You need electron scanning microscopy. You can do PCR, quantitative PCR, pyrosequencing methods. However, we don't all have access to that. And secondly, it actually detects all bacteria in the area, including those that are dead. So you get this huge list of bacteria, and again, you don't know necessarily, well, you You could detect relative amounts of these bacteria, but you don't know if they're the pathogenic bacteria that's causing the problem. Ultimately, for us, it's about how does it impact clinical outcomes? And again, that's a question that I have. But in summary, I think the host is the driving factor. I think bacteria certainly play a role. Perfusion certainly plays a role. Mechanics or tissue mechanics or biomechanics in the lower extremity certainly plays a role. But I think the host drives all of this. And unless we understand our host better, I think our clinical outcomes will be pretty flat. And an example of this I'll give you is in cancer. If you think about cancer therapies, at least they're drug therapies, you often see these commercials, and maybe you know people that have been on cancer therapies where cancer treatment is based on their genomic profile. And we don't have that in wounds. We don't have that certainly in what we do in the limb sparing space. But I think it's a future area of exploration where we should be genomically profiling all of our patients and figuring out what treatments would work best for them. Thank you.
Thank you very much, Paul. Does anyone have any questions? Anybody? Panel? Paul, thanks for your participation this weekend. We appreciate it, and we'll be in touch. Have a good weekend.
You, Jeff. Great. Best of luck.
The next speaker is Dr. Cody Chastain. He is an infectious disease specialist at Vanderbilt University, and he has a special interest in musculoskeletal infections as well as specifically limb salvage situations. Cody, are you there?
I am, Jeff. Can you hear me?
We can hear you. Thank you very much. Look forward to your lecture. Go ahead.
Fantastic. Thank you so much. And I wish I could be there with all of you in person, but as some of my colleagues said, I am glad that we are at least advancing as far as some live conferences in a variety of ways. I'm actually going to start sharing my slideshow here. I will rely on our tech support folks to let me know if it's not visible to you. The title of this talk is Empiric Antibiotics for Limb Salvage. And I probably should have retitled it this, the why, when, and what of empiric antibiotics for limb salvage. I think that a lot of what Dr. Kim just shared is very thoughtful, and I think it is something that we are still struggling with. What are the best strategies for managing infection, biofilms, as well as that interaction with hosts? But I think we all also recognize there are overt times when we encounter patients with classic signs and symptoms of infection, and without antibiotic therapy, those patients have poor outcomes. And in that context, why, when, and what should we use for treatment, particularly when we don't have all the data yet available? I don't have any financial disclosures or conflicts of interest for this talk. And I did want to specifically thank Jeff for the invitation, Dr. Dave, and the other conference organizers, as well as my mentor, David Aronoff, who's my division chief, for sharing some resources for this talk. When we are reflecting on any educational journey, we should think about goals and objectives. And this is a specific objective from today's program that is pertinent to this talk. At the end of this session, you should be able to understand principles that govern empiric antibiotic coverage of limb salvage infections. Notice that principles is what our target here, not exactly what is the one drug you should choose all the time, because quite frankly, there's not. Everyone in the audience today recognizes that limb-threatening infections may occur due to a variety of causes. There's been a lot of discussion about ischemia and the importance of revascularization. One thing we haven't talked a lot about is trauma, but whether it be microtrauma or macrotrauma, we recognize that can introduce infection. And of course, diabetic foot infection is something that has been touched on and will continue to be discussed and seen in your practice. But for the purposes of this discussion, when we talk about empiric antibiotic therapy management, the vast majority of our data and things that are in the literature come from the management of diabetic foot infections. They are common. There's a robust literature about this subject, and a lot of the lessons can be applied to other diseases as well. So let's start with the case. This is a picture of a foot X-ray and MRI in the same patient who's about 67, was referred to the emergency department by a primary care physician because of a new ulceration that was identified. The patient actually has no symptoms. It's not febrile, hasn't noticed any redness, pain, or swelling of the foot. However, the patient has a plain film x-ray performed in the emergency department that shows some gas around the area of the ulcer, some Charcot changes, and then some MRI changes that are suggestive or concerning for osteomyelitis. And as was already mentioned, what does that mean? And in this context, I've got 3 questions that we should ask ourselves when encountering this patient. Are antibiotics warranted? Why or why not? If antibiotics are appropriate, when should they be started? And if empiric antibiotics are initiated, what agents should we select? I would say that the best compilation of evidence that we currently have for limb salvage infections, at least from an infectious disease standpoint, is represented by the International Working Group for the Diabetic Foot, who has most recently updated their guidance in 2019, and this guidance is available online. And I think a lot of the lessons here are actually broadly applicable not only to the diabetic foot, but also other infections that may be limb-threatening. The first question that we need to ask ourselves is fairly straightforward, but it is actually fundamental to everything that comes after. Is the limb infected? We, based on the Infectious Diseases Society of America, as well as the International Working Group for the Diabetic Foot, agree on basically these criteria: that there should be local swelling or induration, erythema, local tenderness or pain, local increased warmth, or purulent drainage. We should have at least 2 of those. It's really important to highlight that's without other causes of an inflammatory response of skin and joint, which may include ischemia, gout, or other things. There's a lot of discretion I think needs to be advised here because antibiotics can often wait without harming the patient, particularly in the absence of systemic symptoms or signs. Antibiotic administration prior to culture acquisition may limit the yield of that culture, and antibiotics delivered for that short period of time may not really benefit the patient, but may actually take away our opportunity to best define what pathogens may be present. This quote I really appreciate from Ben Lipsky in a prior review. It says, the diagnosis of diabetic foot infection, and you could really replace that with limb infection, is based on clinical findings of inflammation rather than solely the results of culture. As Dr. Kim mentioned, we can grow bacteria or identify bacteria through a variety of means or mechanisms. Really, the question is, are antibiotics going to be helpful to that process? So I liken this to driving in the rain on a curvy road. We need to slow down, think, and be cautious before just plowing ahead. So takeaway points number 1 and 2 is that antibiotics should only be administered when there's evidence of infection, not just culture evidence. And culture should be obtained prior to antibiotic therapy when possible to maximize the value for subsequent antibiotic selection. I underlined when possible because I think we also have to wrestle with that point. Why and when should empiric antibiotics be used? Well, going back to the International Working Group for Diabetic Foot classification, there are 4 different levels: uninfected, with has no systemic or local symptoms; mild infection, which is without systemic manifestations and only localized symptoms; moderate infection, or class 3, which is infection without systemic manifestations, but with deep tissue changes or extensive otherwise erythema or other concerning findings. And last but not least, level 4, severe infections, is infection with systemic manifestations, which includes things like fever, tachycardia, a high or a low white blood cell count. This is where I talk about the balance becomes incredibly important because we need to make sure that we're giving our patients the best care in the short term, but also planning for the care in the long term. So my takeaway points number 3 and 4 this talk is that if there's symptoms or signs of systemic infection, which would be the equivalent of class 4 based on this classification, empiric antibiotics should be initiated without waiting for definitive culture acquisition or debridement. We need to prioritize the health of the patient in that context. I will also say, you see, well, hey, Cody, what about this case? What about this case? What about if I'm worried about necrosis, or if I'm worried about rapid progression, or I'm worried about the depth of the infection? There are definitely cases of patients who are on the cusp of developing systemic infection with rapid spread. And I would say that there are definitely moderate infections that warrant empiric therapy, and the provider's discretion should be respected in that context. The other point I should make is here at the bottom. Empiric antibiotics may be administered for non-severe infections once appropriate cultures have been acquired. We don't necessarily need to wait once all the culture data has been acquired that we are going to get. But also, if no further acquisition is planned, perhaps there is not going to be a surgical debridement, or there is not going to be an intervention, or perhaps there's not going to be any more data that will be collected. In that context, empiric antibiotic therapy would be appropriate. Well, you say, okay, well, we talked about whether they need it and why they need it, and maybe perhaps when. Well, what should we use? And fortunately or unfortunately, depending on your perspective, no single agent or combination of agents have been found to be superior for diabetic infections. And this is where the most robust data is present. There's actually randomized controlled trial data to support penicillins, cephalosporins, carbapenems, vancomycin, linezolid, daptomycin, clindamycin, fluoroquinolones, metronidazole. But these have not been put head-to-head in multiple combinations. Typically, a single combination or perhaps a single agent has been compared to a standby historically. And that's left us with a smattering of different data of saying things that could be used, but not with really a linchpin of what specific combination should be used as a framework. So instead of reviewing that, let's talk about some of the general principles of antibiotic treatment and the importance of how we approach this. Effective antibiotic therapy requires accessibility for the patient, requires absorption through administration route, distribution to the location of interest, as well as efficacy against target infection. So let's talk about access to start with. Coming back to our severity classification, I would say that there's a big difference in patients who have severe or moderate infection as compared to those with mild infection or who may not even be infected. Because when I think about the initial antibiotic route, parenteral therapy or IV therapy is really preferred for patients with severe infection or moderate infection with complicating factors. It's also preferred for patients who don't have access to effective oral antibiotic therapy or who can't take effective oral antibiotic therapy. On the other hand, oral therapy may be the most appropriate strategy for mild infection, moderate infection without complicating factors, as well as step-down therapy if the patient initially improves, even while still awaiting culture data or more specific outcomes. What about absorption? Well, the great news is that there are multiple antibiotics that have sufficient oral absorption for us to respect their use for treatment of limb salvage. And there's increasing data about the use of oral antibiotics, either as step-down therapy or for long-course therapy, even in complex infections such as osteomyelitis. When we think about treatment of patients with limb salvage or limb infections, particularly in the context of the diabetic foot, we are predominantly recognizing that this is a polymicrobial process, often including Staphylococcus and Streptococcus. So at our bare minimum, antibiotics that cover these like cephalexin, amoxicillin, clavulanate, and clindamycin should be considered. And they all have good oral bioavailability. We do recognize that MRSA infection is increasingly present in all of our communities. And in that context, trimethoprim sulfamethoxazole, doxycycline, clindamycin, and linezolid may be considered. And Pseudomonas may be an important pathogen in select patients, and I'll come back to that in a moment. And ciprofloxacin and levofloxacin may be considered. Ultimately, the final antibiotic selection should be guided based on the available data. However, these are all potential options to be used as oral therapies. You may have noticed that I put in italics delafloxacin, which is actually a relatively new fluoroquinolone that came to the market over the past 2 years. This is actually a fluoroquinolone that has good bioavailability and actually has efficacy against MRSA and Pseudomonas, which is our only oral therapy that does both. However, it's a very expensive antibiotic, and we actually have very little data about clinical outcomes in this patient population. And so in this context, we are worried about how this will pan out over time, particularly since Staphylococcus aureus developed resistance to ciprofloxacin and levofloxacin very quickly in the community. Last general principle of antibiotic treatment is it going to be effective against target infection? And this is where I think some of the talks that we've already heard today from Dr. Steinberg, from Dr. Jacobs and others, is that we need to look at our patients. We need to examine our patients, and we need to use the history and the physical exam in that context to help us to select. Because the presentation of whether it's cellulitis, whether it's infected ulcer, whether they've taken antibiotics before, whether they've been soaking their foot, whether there's evidence of necrosis, all of these have factors in indicating the pathogens that may be at play, whether it be strep, staph, Pseudomonas, multi-drug-resistant pathogens, or anaerobes. General pearls include that if a patient's had recent antibiotics, and if you're in a community that has a high burden of MRSA, including that as an empiric option may be appropriate. If you have a patient who's had a chronic infection with prior treatment failure, gram-negative bacteria should be covered. And if you're examining a patient who has necrosis, gangrene, or foul smell to the tissue or wound, anaerobic bacteria may be appropriate to be treated. I've left this slide here as a resource for all, not to guide you to a specific therapy, whether it be IV or oral, but to demonstrate that there are a combination of different options that may be appropriate and may be something to select based on your patient's history, their exam, their severity of illness, as well as their allergy profile. But we have a host of different options, and in part that's because, as Dr. Kim mentioned, this is often in the context of polymicrobial infections, and what does it mean when we get certain culture or certain data back? And ultimately, these are empiric antibiotic regimens that have performed well in clinical trials, and you could feel that you're within the standard of care by offering these approaches. The takeaway points 5 and 6 is that if empiric antibiotic therapy is appropriate, prescribed therapy based on its accessibility, absorption, distribution, and efficacy, and ensure that staph and strep are included. Consider whether MRSA, Pseudomonas, or anaerobic bacteria are appropriate based on clinical features when you're selecting empiric antibiotics. Before I stop, you might say, wait, well, what about ischemic limbs? Well, what I would say to start with, it's not all that much different than when we talk about a diabetic foot. First of all, you have to determine if infection is present or not. Just because a patient is ischemic or just because they have an ulceration does not mean an infection is present. Once you determine if an infection is present, then you have to determine the severity of the infection as well as timing of revascularization and or debridement. We should recognize that distribution of any antibiotic may be limited by vascular flow, but it's not eliminated. And so we have to keep that in context. And ultimately, we also need to watch out for rapid progression of gangrene and determine whether we think that's from ischemia or infection. You say, wait, you've mentioned trauma at the very beginning. What about trauma? I would say that's a complicated subject. It would take far more than my total of 15 minutes to talk about on its own. But some quick rules of thumb is that when we talk about open fractures as a source for trauma, our empiric antibiotic approach is determined based on the fracture severity, as well as the presence or absence of soil or water contamination. Our baseline coverage still covers staph and strep, but if soil contamination present, we think about covering anaerobic bacteria. If freshwater contamination is present, we think about expanding the spectrum to include gram-negative pathogens. And if actually salt or seawater is included, we have to think about certain atypical pathogens that may warrant fluoroquinolones or doxycycline. I appreciate your time this morning. I really appreciate the opportunity to work across and collaborate with others. And in this context, I'll be talking a little bit more of that collaboration later this morning, or I guess where you are in the afternoon. I'm happy to take questions.
Anybody have any questions on empiric antibiotics? Yes.
Thank you very much. Dr. Chastain, my question is, when do you recommend stopping antibiotics prior to doing a bone biopsy?
Yeah, so that's a great question. So I think fundamental question is, if we're talking about holding antibiotics when we actually have a patient who has infection, my question would subsequently be, what's the risk and benefit? And I'll actually have an image later signifying a scale, because anytime we talk about either giving antibiotics or withholding antibiotics, it's got to be in the context of a risk benefit. I would say that if a patient is clinically stable and there is an anticipated bone biopsy, particularly as an outpatient, generally speaking, we would like to hold antibiotics to maximize culture yield for a minimum of 3 days and out to 1 to 2 weeks. That being said, if you've already initiated antibiotics or a colleague has initiated antibiotics because of fear of disease progression in the interim, we should also recognize and respect that. If a bone biopsy is obtained and no pathogens grow, at the very minimum, you can recognize that either your antibiotic selection is effective or sterilizing the culture, or that you have to question whether it was infected in the first place. Alternatively, if a pathogen grows, we recognize that we have to augment the current coverage to include the pathogen that was present. So I think we have to balance the risk and benefit to the patient. I would feel very differently if we have a hospitalized patient who has warranted antibiotics because of a moderate or severe infection. In that context, I would interpret the culture data. I would not necessarily hold the antibiotics just to optimize my culture yield. Hopefully that's helpful.
Yeah, thank you.
Any other questions? Yes.
Yes, thanks for the lecture. It was informative. And I just have a question about decision-making between from a patient that presents in the office and you go ahead and obtain a culture, do you like to start with IV if it's in that moderate category to really knock out an infection and then maybe step down to oral, or start with oral, pen culture, and then determine if IV would be needed?
Yeah, so I think that's a great question. And Jeff and I have actually had some curbside and also kind of discussions off the cuff about this. And this is all about that risk and benefit to the patient, right? We don't want that patient under our watch, as Dr. Jacobs mentioned, to progress. If we know there's a problem, we want to address that problem. I would say that a patient who is in the outpatient setting without systemic infection, I would likely start with oral antibiotics in that context, particularly if we choose oral antibiotics with good oral bioavailability. I will honestly say my personal bias is that as we study this question, each time we ask the question of whether oral is the equivalent of IV, every time we ask that question and we study it well, we have found that oral antibiotics are the equivalent and are not inferior. We have not completely done all the studies necessary in that context, but I think that there's a robust well of data at this point to say that oral antibiotics are likely as effective as IV antibiotics, provided that an orally bioavailable agent is used and provided it meets those other parameters that it's appropriate in spectrum and activity. So a patient who does not warrant hospitalization otherwise and can effectively access an oral therapy that's bioavailable, I would likely start in that context. A patient who requires hospitalization or emergency evaluation because of systemic symptoms, I would feel very differently.
Any other questions? Thank you very much, Dr. Chastain. I'm going to go ahead with the next lecture. Go ahead and put the slides up, please. And I want to talk about radiologic imaging. I'm going to talk about what I think are kind of the basic things that we need to consider when doing our radiographic workup or radiologic workup on these patients. And so, in general, I'm going to try to make this more clinically appropriate for when you see a patient in the hospital or in the office, and how you need to approach these patients, and not based on my opinion or subjectivity on my part, but based upon guidelines which are relatively proven guidelines that work in this patient subset. And so we're going to talk about, I have no disclosures or conflicts of interest. We're going to talk about kind of a diagnostic approach from a radiologic standpoint for osteomyelitis, because that's essentially the big question that we ask about in many of these patients. Does the patient have an underlying osteomyelitis with a diabetic foot ulcer or diabetic foot infection? And that's what we're going to talk about at the beginning. And then we're going to look at, and I'm going to try to go over MRI from a very basic, simplistic standpoint with the idea that you can have a couple of take-home points that will hopefully positively affect your practice. And we'll talk very briefly about other modalities, and I'm going to make some generalized comments on, there's a number of different scanning options, nuclear medicine options that are available and are in the process of being validated, studied, and I'll kind of comment on how I think those affect my practice, your practice. And so when we see a patient we got the suspicion of osteomyelitis, we talk about a few things, and this is in the IDSA guidelines from 2012, and then the international group that Dr. Chastain mentioned from 2019. And I think these are both good references and reviews for this group of patients. But we want to do three things. We want to do a probe to bone test, and there's a little bit of there's a little bit of discrepancy with this, and I think there's a couple things you need to keep in mind with this. It's very operator dependent. If you take a sterile instrument and you push really hard, you're going to get a positive test every time. So you have to have some sort of process that you try to standardize in your own mind when you do this test. It is typically has a good positive predictive value in patients with high risk, and so we typically will use this in every patient, and in general, its negative predictive value is very good in patients with low risk. We typically would recommend to get inflammatory markers in all these patients, and that's going to be a SED rate, a C-reactive protein, or potentially procalcitonin if that's something that you believe in, and I think the verdict's still out on procalcitonin to a large degree. And then The first thing that you need to get are plain radiographs. This is true in any new diabetic foot ulcer or diabetic foot infection that comes to the office. You need to get standard foot films, whether they're weight-bearing or not. I don't think it's a huge issue. But one of the things I would tell you is it's very important to get these in all patients, even if they just have an ulcer but don't have an infection, because you need to have a baseline to compare to. And oftentimes, for some reason, those films aren't done, the patient doesn't do well, and 3 months down the line, they've got a bad infection, and we have nothing to compare to. So it's important to get baseline films, even in patients that you may not have an infection but have an ulcer. And then the other thing to consider is this. A lot of times we get baseline films in patients. We're unsure of what we're seeing on the films. Always think about getting contralateral films. It's sometimes a hassle, sometimes it's difficult to get paid for them, but oftentimes they yield significant information that may affect your treatment. And so we get the films, and I'll just give you a couple of examples. And typically, in this patient had a vascular problem, had gangrene, but also had an acute infection related to this. White count was in the 30,000s, and why do we get x-rays? Well, we want to look for gas in the soft tissue, and you can see plantar to the digits in the distal forefoot, we have gas in the soft tissue. So it's important to get these films. Also, we deal with a lot of patients with neuropathy. Retained foreign bodies are not unheard of, and so we need to get plain films to look for these types of problems. And then other things that we do, this is a patient that had this ulcer for probably 3 months before I saw her. I practiced in Pakistan for about 4 months, and this was one of my first patients to see. And they had never gotten any films, and the answer was, well, we know the bone's infected, we can see it, we can feel it, she's doing better on antibiotics, and she can kind of wax and wane. She'd go on antibiotics for 2 or 3 weeks, get better, they take her off. And so there was an issue about why this patient wasn't getting better, and I said, well, why don't we just get some plain films? And so a couple of things. We've got fragmentation of the distal lateral malleolus. We've got rarefaction of the bone of the distal lateral malleolus. And then what else? We've got probably a septic joint. So even when you don't think you need to have the films, you think things are very clinically evident, it's always good to have baseline films in these patients as you go down the line in your treatment process. So in the same patient, the patient with suspected osteomyelitis, a lot of times we get plain films, we do our clinical examination, we get some type of inflammatory marker, and we have a pretty comfortable feeling about whether we think the patient has osteomyelitis or not. And the international group's guidelines are to not go any further and to investigate this any further. And I think in some patients that is reasonable. But I would tell you, from my standpoint, if I think the patient has an infection under those circumstances, or if we get the plain films and we're not sure, my next line or my next test in this patient group is to get an MRI. And I would suggest to you that MRI is the workhorse modality for looking at potential infections in this subset of patients, specifically diabetic patients. I would also tell you this, and this is probably one of the most important take-home messages. There are a lot of different nuclear medicine tests, PET scans, other types of modalities to evaluate bone infection or osteomyelitis. What you have to make sure of is that where you are in practice clinically, geographic location, do they do those studies on a regular basis? As an example, okay, in West Virginia, every hospital in West Virginia has an MRI unit or has access to an MRI unit. 4 have access to PET scans for this type of workup for an osteomyelitis patient. So it's nice to look at these studies, and they have valuable information, but you have to make sure that what you want to do is possible and that whoever's doing it does it on a regular basis, because most radiologists look at MRIs for infection on a very regular basis. So that's an important take-home message. The IDSA guidelines from 2012, once again, MRI is their most strongly recommended radiologic test after plain films in the continued workup for osteomyelitis. Now, certainly there are going to be patients that cannot have MRIs, and we'll talk about that briefly at the end. Here's the thing that you need to worry about with MRIs. There's a couple of issues. One, the top part of this, We don't see any definitive evidence of osteomyelitis. Clinical correlation is recommended. How many times has everyone seen that on a report? I mean, all the time, right? And then the next part has been added in the past 10 years, repeat the MRI in 7 days if clinically warranted. So I think that that's a reasonable thing to see on a report, but what that means to me is this. I need to learn some basics to be able to look at the MRI because I have the most information because I'm seeing the patient clinically. I'm looking at the test versus the radiologist who's only looking at the study. So you have an advantage, and it's important that you learn basic principles of how to look at these so you can get the best information possible. And it's not uncommon. You look at that's a quote at the bottom, and I think it's important. When we talk about MRI, everyone pretty much knows how to read plain films because we look at them all the time. We have a pretty good idea of about how to read CT, but we really don't spend as much time because we're a little bit afraid of MRI because there's lots of different pulse sequences. We don't know what a lot of it means, but we need to spend more time to use this test because it's absolutely a valuable and a very potent test to help us solve clinical problems. So when we look at MRIs in this patient group, there are primary and secondary findings, and I'm just going to go over a couple of clinical examples with respect to this. Typically, radiologists, and if you're looking at information on MRI and musculoskeletal infections, you look at a guy named Mark Schweitzer. He's probably done the most benchmark work, research, publications on this for the past 25 years, or Zahava Rosenberg, those two people. And this is from one of their articles. They look at the primary and secondary findings, ulcer, cellulitis, soft tissue mass, abscess, sinus tract, and cortical interruption. These things, if you see them in conjunction with your clinical evaluation and your plain film inspection, they are highly suggestive of osteomyelitis, okay? And I'll just give you an example. This is a patient of mine, and this guy's a diabetic, great patient. If I asked him to do 7 things, he did all 7 of them to a T. Couldn't ask for a better patient. He came into the office, he was working in the attic, puncture wound about a week before he came into the office, and he ended up with the septic arthritis of his HIPJ, okay? And actually, he was febrile, he had a white count, so we admitted him to the hospital, did an arthrotomy, open, cultured him, put him on IV antibiotics for 2 weeks, and then stepped down oral antibiotics for a remainder of the 6-week course. He did great for about, I don't know, 3.5 months. He was off antibiotics, no problems. And then he developed a paronychia. His entire nail plate got infected for no real reason. I took it off about 2 weeks prior to this visit. He comes into the office, nail bed looks good, but now we got a sinus tract at his Alexander phalangeal joint. So what do? So here's his MRI on the bottom. And just as a general comment, I'm going to talk about this throughout the lecture, if you see MRIs and the bone is black, that is a water-weighted image. That is either typically a fast spin echo T2 image or a stir. You get one or both of those in every MRI that you order. It looks for inflammation. So just remember that. Bone is black. You're looking for inflammation, which is high signal intensity, which you can see in the distal phalanx here, okay? And they're water-weighted images. So you can see on the MRI at the bottom, his distal phalanx lights up on all 3 images. And then if you look at the x-ray, which is at the same time you came in for the office visit, look at the rarefaction of the medial half of his distal phalanx. So the joint doesn't look that bad, but it looks like he's got an osteo of his distal phalanx. And so he eventually went in after we admitted him and put him on antibiotics and had an amputation. And I always like to try to correlate specimens with radiographs and MRI. And this is his distal phalanx, and you can see the pus in the distal phalanx. And so this is a pretty clear example of what a sinus tract can mean in the face of a prior joint infection, and looking at our MRI so you can kind of get a baseline of what we see with this type of infection. Now let's look at an ulcer. This is a patient, okay, and I'm going to show you the clinical picture in just a minute. These are also water-weighted images. I haven't showed you any T1 weighted images yet, so these are water-weighted images, and these are fast spin echo T2 images, okay? And what we see, if you look at the middle picture, is if you look at the fifth metatarsal, there is increased signal intensity, so there's whiteness within the bone. And then if you look on your right-hand side of the screen, those are the sagittal cuts. This same whiteness is within the bone. So this patient was referred by the general surgeon, and he had this ulcer for 3 months, and he'd been walking on his fifth metatarsal head for 3 months. Now, there was no reason to get the MRI. The patient was sent to the ER, and just by knee jerk, the ER doc ordered an MRI, which is a good teaching thing. So, but you can see that this patient has an ulcer, direct extension osteomyelitis to the fifth metatarsal. And we'll talk about how we evaluate these patients and add a T1 weighted image to make sure that as best we can that they have osteo and not just increased stress on the metatarsal from a biomechanical reason. So when we look at MRIs, we see focally decreased marrow signal intensity on a T1 weighted image. So a T1 weighted image is where the bones are white. It's a fat weighted image. It tells us anatomy. And so when we see decreased marrow signal intensity, that's low signal intensity, that's gray or black, okay? We see focal increased marrow signal intensity on T2 weighted images, so the bone lights up. It's a black bone that goes white. And then we'll talk about enhancement a little bit. We see focal marrow enhancement with gadolinium enhanced images. So the main thing that you need to take home from this is if you know what the difference between T2 weighted and T1 weighted images is this. You must have a corresponding T1 weighted image to go with your T2 weighted image to give you a much better idea if the patient really has osteomyelitis. If you just look at your T2 weighted images, you will overread for osteomyelitis. Just remember that. That's an important point when you're looking at these. And then when you look at your T1 weighted images, you look at the distribution. Is it geographic or is it subcortical? You look at the pattern distribution. Is it confluent? Is it contiguous with the ulcer, or is it reticulated or heterogeneous? And we'll go over some examples of this. And this is just a schematic of confluent intramedullary versus reticular versus subcortical. And so on the left is your water-weighted image, and that's a fast spin echo T2. Okay, we got good anatomic detail, and we also have a water-weighted image. And you can see that there's signal intensity in the proximal phalanx of the second toe. Now look at the T1 weighted image on your right. Okay, we've got cortical disruption. We've got confluence between the outside of the bone and the inside of the bone. And we have what I would say is a geographic distribution. We don't see a zone of transition. Okay? If there's no zone of transition, then you can say that it's geographic. So this is probably equivalent to osteomyelitis. A couple of other examples. The top two pictures are fifth metatarsal. The top picture is a first ray. The middle picture is a fifth ray. And then the bottom picture is what I want you to focus on. This is a patient that has an ulcer submetatarsal head. On the left bottom, it's a T2 weighted image. Okay, so it's a water weighted image. And we have increased signal intensity in the plantar half of the metatarsal head, correct? So that is concerning for osteomyelitis. However, when we look at the T1 weighted image corresponding to this, we see that subcortical kind of pattern. We don't see a confluence between the ulcer through the cortex and into the marrow. So this was biopsy negative for osteomyelitis. And so this is a good way to just very simply look at these patients, clinical exam, plain film evaluation, and then you get your MRI in patients that you're not sure of. And this isn't that difficult to go through this, a simple T2 and T1 weighted image. Here's a calcaneal ulcer. I mean, everyone sees these on a regular basis. Top picture, top left, this is a water-weighted image. We're looking for inflammation. There is some inflammation at the arrow, but we see this subcortical, non-confluent pattern on the T1 weighted image. Negative bone biopsy, negative for osteo, versus the bottom image, you can see confluence between the ulcer through the cortex and into the bone, right? That was biopsy positive for osteomyelitis. And this is even a better example. So it's a T2 weighted image on the left, probably the plantar 2/3 of the calcaneus lit up, right? There's the T1 weighted image. So if you have concordance between the T2 and T1 weighted image, okay, that is very suggestive of osteomyelitis, okay? That's important. Why is it important? I'll show you this case. This will illustrate why. This guy, I inherited this patient, great patient, but this guy, he's 6'7", 280, okay? That ulcer that he has on the bottom of his heel right there, he had had 2 years prior to me seeing him. He went to wound care clinic every week for 2 years. All kinds of wound care products, all kinds of debridements, all kinds of antibiotics. What do you think the prospects of healing that are if he doesn't stay off of his foot? 0, right? It's not gonna happen. He wouldn't stay off of his foot. He had wound care evaluation and treatment probably 3 or 4 days prior to this. I got a call from the ER, and this is what his foot looks like. Obviously, he's got a horrible infection, okay? This guy also has some pulmonary problems, he's diabetic, and he has ischemic heart disease. So he's got significant comorbidities, he gets admitted. You know, this is a guy we worry about losing his leg. Here's his plain films. You can see the ulcer, you can see the soft tissue, probably has some gas in the soft tissue, but actually the bone, his calcaneus, there's no rarefaction of bone, there's no localized osteopenia, there's no cortical deficit. The marrow pattern, you know, the trabecular pattern looks normal. So all the things that we look at as secondary findings for osteo in a calcaneus on plain film are not there. Guy's white counts over 30,000, his SED rates 70, 80. So, you know, this is a guy we worry about osteo. So I'm gonna debride this guy. Why do we get the MRI? Well, I know he has a horrible infection, soft tissue infection. If I don't have to, I do not want to penetrate his calcaneus and potentially spread the soft tissue infection into the bone. Okay, I want to try to avoid that if I can. So we get the MRI, and these are just T1 weighted and T2 weighted images side by side, okay? He does have some artifact. That's what you see on the bottom right-hand side of all these pictures. He had a small needle in his foot he'd had in there for 4 or 5 years. But if you look at all of these images, and you look at the cortex lateral in the calcaneus on the T1 weighted image and then follow it with the T2 weighted image, there isn't suggestion of osteomyelitis. The cortex looks like it's intact. And so on these images, I'm happy. Now we look at the coronal images. The same thing, if you look at the plantar aspect of the calcaneus, on the T2 weighted images, there is some increased signal intensity, suggestive of inflammation. We don't know why that inflammation is there, though. If we look at the corresponding T1 weighted images, I don't see any involvement. And if there is, there may be slight. It's subcortical and not confluent or geographic. So I'm not worried about osteomyelitis with this guy based on these MRIs. Those are the sagittal cuts and pretty much the same thing. So what do? We debrided him. And this guy got sick. He got transferred to the unit, got intubated. You know, he was in the unit for a week, which is horrible for him, but good for me because he's off of his foot for a week. I know that sounds crazy, but you'll see why I say that. So now, those first films were on 3/15, I believe. These are 5/3/16. So the guy's been in the hospital for 2 or 3 weeks. Then he gets sent to a transitional care unit, and these films were first outpatient visit in my office prior to him going home. Films still look okay. Look at his ulcer. And he got culture-directed antibiotics, he got good debridement, but the reason that looks better on the plantar aspect of his foot is because he's been off of it. All right? Laterally, this wound, I just elected to let it fill in. Wound vac and some wound care products. Now, this is about 3 weeks later. Plain films still look okay. Guess what happened in between? Home health care nurse called me and said, hey, your patient, he fell in the front yard. My immediate question was, well, what's he doing in the front yard? He goes, well, he went out to pick up a bunch of sticks that were in the yard. Well, now I know we're going back in the wrong direction. He's walking on it again, and you can see that the ulcer plantarly is getting worse, laterally is getting better. He's been off antibiotics for 6 weeks. So we go through this process, and plantar ulcer continues to get worse, lateral one is healing up. And now we're 10/17/16. So this is 7 months after I saw him in the hospital. He continues to walk on it. He's not on any antibiotics, and uh-oh is the correct answer. Now he presents to the emergency room. He steps down on it, and he has a pathologic fracture. And this is a pathologic fracture from osteomyelitis, which is very rare. Now let's look at the MRI. All sequences, and I'm going to tell you, at this hospital when they gave gadolinium, instead of doing T1 weighted images, they do fat suppression T1 weighted images. What's that mean? The bone is black, but we still have the anatomic detail. So in all of these, we see increased signal intensity, okay? All planes. And so now the guy has osteomyelitis, and essentially he ended up with an amputation after failed treatment of fracture repair, X-fix, all that stuff. So when an MRI is contraindicated, I still think that there's a place for technesium scans, and hopefully Dr. Jakes will comment on that if he's listening. And there's some other tests that you could run, and I think that we're out of time, but here's the take home, and I will repeat this. Find out what they do at your hospital and how often they do it, because different radiologists and different hospitals do different tests with respect to nuclear medicine and ancillary imaging for osteo when MRI is not available or contraindicated. This is just a quick example of bone, just straight bone scan. It's a patient of mine, he'd been in the hospital twice. I saw him the third time that he was in the hospital. He had an ulcer at the bottom of his hallux. It probed the bone. Plain films were unremarkable, equivocal. There's his bone scan. Now, I'm concerned because it looks like the HIPJ lit up as well as the distal phalanx. And there's his probe the bone, and pus came out of it when I removed the hemostat. Well, if you look at his plain film a little more closely, and I asked him about this, he had remote trauma at his hallux interphalangeal joint, and that does correspond to that other area of increased uptake. And so what that meant to me was the bone infection is probably in the distal phalanx, and that accounts for the distal uptake. The more proximal uptake is probably from remote trauma. Why is that an issue? Well, when I did this guy's Symes amputation, I want to maintain as much of the hallux as I can, and so I basically took it off at the head of the proximal phalanx. So hopefully, we've kind of go over some basics on radiologic workup of these patients and kind of go over some simple stuff with respect to MRI that's hopefully helpful in your clinical practice. Any questions?
Quick question.
Yes.
About the calcaneal surgery that you did. Now, with the MRI results, it showed no osteo.
On the first time.
On the first time.
That's correct.
And would you have considered a bone biopsy at that time, or were you nervous about spreading the infection into the bone?
That was the big debate, and we
Yeah.
had infectious disease, and I didn't want to because of how significant the soft tissue infection was. And with those findings on MRI, the fact that he responded to a debridement and IV antibiotics, we elected not to do the bone biopsy because I did not want to do that. I didn't want to potentially spread it to the medullary canal, the calcaneus. And so, and I think we were probably correct because he was on antibiotics for 6 weeks, and clinically he did better for months. We could have been, there's no question we could have been wrong. And I think he eventually got an osteo in his heel just from continued walking on, and then got the pathologic fracture. Go ahead.
So a quick follow-up question to that. In our wound clinic, we have an ID doctor, and they push bone biopsy a lot.
Yeah.
What's your take on that? Even with a wound, even if the wound doesn't go to bone, they want us to try and get that bone biopsy instead of the MRI. And
I think that there's two issues with respect to bone biopsies that I'm going to say that are negative. I think bone biopsies are good in the right clinical situation. There's two things to consider. When you do a bone biopsy, especially in the calcaneus, you have to worry about stress risers. I can't tell you how many times I've had patients referred because they've had a negative biopsy, but they've got a pathologic fracture through the biopsy site. So that's something to consider. How big, what's the circumference of your biopsy? Don't go through both cortices, just the cortex that's of concern. So that would be my first thing. My second thing is, and this goes back to Dr. Kim's discussion and our culture discussion, there's disconcordance between path and micro findings on bone biopsies and cultures all the time. So I don't know that that is a great thing to hang your hat on in every case. Now, certainly in some instances, when it's clinically warranted, I think you need to do it. You have a horrible infection that's not getting better with conventional means. You don't have any evidence of osteo. I think, in that case, I think you got to do something to further investigate. MRI's equivocal, that sort of thing. But I don't know that I would have a blanketed approach that I biopsy everyone, or it's my first step to treating the patients. Does that make sense?
yeah, it does, absolutely. Thank you.
Thank you. Next up, Dr. Dave is going to give the second part of his revascularization lecture. Thank you, Dr. Dave.
Thank you. So it's me between you and lunch. So I'll be very brief and try to. So what has changed in last 20 years? First of all, understanding of the disease has changed. Options of treatments have changed. We have moved from large surgery to minimally invasive procedures and allow a greater number of patients of all age groups can be treated, and equipment has substantially improved. And that shows in our US national trend. You can see that from year 2002, the line which is blue is endovascular interventions have exploded. And is significantly higher. Lower extremity bypass surgery has exponentially declined, and we have bent the amputation curve as well. So this is the latest data from Medicare. So let's talk about a few new technologies. One of the issues that plagues the endovascular revascularization is restenosis. And there are multiple ways to treat restenosis, including drug-coated balloons and conventional treatments such as atherectomy and balloon angioplasty. However, there is a lot of controversy now regarding drug-eluting balloons, whether they are harmful to the patient. This is a technology, this is now available to us. It's called Eluvia. It's a self-expanding nitinol stent, which is actually coated with a polymer, which allows a control the release of paclitaxel. There is another stent available on the market, which is also coated with paclitaxel. However, it does not have polymer coating, so it's sort of dipped into a paclitaxel solution, and when we put it into the body, the paclitaxel is immediately released. You see, here's a inner structure of how a stent strut is constructed. So you can see that there is an active layer with a primer in it. This is the effectiveness of this device comparison to the other device that is coated just with paclitaxel without a polymer. And you can see that there is modest but definite improvement in the primary patency rate of the femoral artery at 2 years with a Eluvia type of drug-eluting stents. However, these are all simple patients in randomized clinical trials, and however, we do see some promising results with this technology. Here's an example of a patient who has a non-healing wound of the right foot for about 8 months. He has severe cardiomyopathy, multiple comorbidities, 72-year-old gentleman. And you can see where his problem is. His profunda femoris artery, deep femoral artery, is basically non-existent. It's not filling. There is a very large amount of calcium in the common femoral artery, which extends into the origin of the SFA, and there is a severe stenosis. You know, this is a patient you would require if you want to do a surgical exploration, would require general anesthesia with his ejection fraction of 20%. Would not be the most ideal situation to put this patient under. The next run will show you the large calcium. So the question is, how can we deal with it? So the way we dealt with this particular case is we used a device called orbital atherectomy, and I encourage you at the lunchtime to visit our exhibitors. CSI, which is the company that sells this device, is actually in the exhibit hall, and they have this device. You can see it. But this is a diamond-coated eccentric burr that spins through the artery, and it sandblasts the calcium. Now, in an extreme situation like in this particular patient, this is the CSI which was done. Now, on top of that, we also use the intravascular lithotripsy. So you have all heard of lithotripsy that's used for kidney stones. Now, the same technology in a modified fashion is being utilized in the femoral and the below knee arteries. We are one of the leading centers for doing lithoplasty, and you can see how lithoplasty works, how those pressure waves are being sent through the balloon into the vessel wall, which basically disrupts all calcium. So This was done to this calcified lesion. You can see this lithoplasty balloon in place in a common femoral artery. And this calcium was blasted away by lithoplasty, and then we performed something called a cryoplasty on top of that to freeze the inner lining of the vessel, and this was the final outcome without doing any kind of surgery, less than a 30-minute procedure. This is this full runoff after treating the common femoral artery. You can see that he has a flow all the way to the foot through the peroneal and the posterior tibial artery. And this patient's ultimately, the wound healed up, and he was doing fine. Here's another gentleman who actually came from orthopedic surgeon, and he has been complaining of back pain for a long time, and now was complaining of lower extremity claudication, and also had severe coronary artery disease. And he was found to have bilateral iliac occlusion, was referred for surgical revascularization. Surgeon recommended that he would need aorta bifemoral bypass. However, due to his coronary artery disease, there is no other option. They could consider it. However, they recommended that we would just treat the patient with medical therapy. So the patient was suffering a lot from claudication, came to me as a second opinion. This is a procedure that we do very commonly of heavily calcified iliac occlusions. You can see that this is a ICARAS trial that I was one of the co-authors of. This is with a balloon expandable covered stent graft. This was just published a couple months ago, 3-year results from ICARAS study. We also published, which I was part of, a systematic review of the covered balloon expandable stents in treating aortoiliac occlusive disease, a 7-year follow-up. And I'm going to show you this with, this is the stent which is utilized for this type of procedure. You can see the stent is actually baked inside a PTFE solution and is covered by PTFE that provides a safety margin on inflating these type of devices in these complex iliac lesions without perforation, provides over 90% patency rate at 5 years. This is the procedural steps, which I won't go into, but a brachial access was obtained, a retrograde wire crossing of left iliac occlusion was performed. There is a snare device which was introduced from a femoral sheath in the left side, and the wire was snared out. Then an attempt was made to cross the right-sided occlusion from both sides, but it failed. So a wire from above failed, a wire from below failed. So in that case, a Pioneer re-entry device was used. It's a device that utilizes intravascular ultrasound and a needle that punctures into the normal wall of the artery and allows access back into the true lumen of this vessel. Now, once that procedure was performed, I performed balloon angioplasty on both sides to create the space. Now this ICAST balloon expandable covered stent grafts are deployed, and this was the final result for this patient. This patient is now almost 15 years out of it. From this procedure, it remains completely asymptomatic. This iliac stents still remain patent. He has no claudication. Here's another example of how a technology can help us. This is a diabetic patient with a recurrent non-healing ulcer of the right foot. He also has rest pain. He had a prior 2 BTK interventions at an outlying facility. And because he had recurrent critical limb ischemia, he was sent to me. You can see this anterior tibial artery is totally occluded. His tibioperineal trunk is totally occluded. A thin posterior tibial artery is in, which is also distally occluded. The peroneal artery is totally occluded. And you can see a faint reconstitution of the dorsalis pedis in a posterior tibial artery in a late arterial phase on a contrast angiography. And Dr. Kim, I'm glad to hear that was recommending contrast angiography for many of these patients. So now you can see that what we have done here through a microcatheter, we are utilizing a 014 guide wire to place this microcatheter beyond the occlusion of the anterior tibial artery so that we can perform foot angiography. I showed this slide earlier today that completing plantar loop is very important for these CLI patients. Now a laser atherectomy was performed. A very tip at the very top you see is the laser catheter. And then after laser atherectomy, you can see that the anterior tibialis is patent now. However, you can see that even though anterior tibial artery is patent, there is not a lot of flow into the plantar arch. I can almost guarantee you that 99% of the vascular doctors would do this procedure and say, okay, we are done. We got what we have, and it's completely insufficient. Okay, this is where a plantar loop revascularization is absolutely important. Otherwise, this patient will come back for sure. So now you can see that 10 days later, the patient was brought back, and you can see a slightly better flow, but not complete plantar loop arch. So now you can see a wire going from anterior tibial artery through plantar loop back into the posterior tibial artery, and retrogradely a posterior tibial artery was balloon angioplasty. Now we attempted to cross the entire occlusion of the posterior tibial artery from the retrograde fashion like I showed earlier today, and it was not successful. So here we also had to utilize a coronary CTO technique. A reverse card procedure had to be performed to ultimately navigate through the posterior tibial artery, and this is the final result. You can see a tibioperoneal trunk is open now, the posterior tibial artery is open, and the plantar loop is now completed, and the patient has a substantially better flow. Here is another example of it. We'll move pretty quickly in the interest of time. You can see the posterior tibial artery is distally occluded. The anterior tibial artery constitutes. The peroneal artery is also distally occluded. This is another critical limb ischemia patient. In this case, the posterior tibial artery occlusion was attempted. It failed, so we were able to navigate through the anterior tibial artery. And now we have opened up the AT. And you can see that the AT is open, and now we're attempting a similar procedure like we did on the last patient to return back into the posterior tibial artery so we can complete the plantar loop, and we can have two antegrade vessels flowing into the patient's foot. And you can see this is a procedural steps, an attempt from the top with a Corsair microcatheter, that's the Japanese catheter, and a retrograde wire going in both directions. So you can see that the direction was not correct, which was then corrected. And now an orbital atherectomy, which is the device that I showed you earlier, was performed because of the heavily calcified posterior tibial artery. Now this was ballooned, and now the plantar loop was completed. In this patient, you can see now a foot angiography is so critically important for us to assess whether perfusion is enough for this type of situation. So in summary, in 2020, no one should get an amputation unless all options are exhausted. Awareness, early treatment, and increasing experience are improving the outcomes. New technology increases the likelihood of below-knee revascularization and plantar loop reconstruction. And it is certainly a team sport between interventionalists, surgeon, and folks in the wound care arena, whether they are from surgical team or whether they are from a podiatry team. All of us need to leave our egos at the door if we are ever going to save these patients' legs. So thank you very much. I think it's just a glimpse on all these things that we do, all the new technologies that we use. And we'll continue to have this dialogue every few months, and I invite everyone who is here today to actively participate. Next time, we would love for you to bring your cases. We will have more interaction, and some of you be able to speak. The other announcement that I want to make today is we have a departing gift for everybody, but I'm going to tell you what it is. One of our C3 course co-directors, his name is Dr. Imad Shaiban, is a very famous interventional cardiologist in Verona, Italy. He introduced me to a friend of his who is a recipient of some of our procedures, and his name is Fred Tomasi. Fred Tomasi is a very well-known name in Italy because they are a owner of a huge winery. Heather and I had the pleasure of being at the Fred Tomasi winery. We recently spoke to Mr. Tomasi, and Mr. Tomasi was very thankful to all first responders in the COVID time. So he donated 50 bottles of Tomasi wine for all of you. And they're out there. And please have one of these on your way home. And in future, maybe when you go to Italy, once it opens up, you get to visit Tomasi Winery. So these are in the hallway. Feel free to take a bottle of wine with you at home and with a box. So with that, I conclude, and thank you very much. Have lunch. Please visit our exhibitors in the lunchroom, and then we'll gather after lunch for the final session. Thank you very much. Oh, by the way, the lunch is not in the exhibit hall. It's in the Coco room. But there's signs out there. Very nice. Here, that's you. they've done talk earlier today?
He did one earlier. He did one end of the first session.
But you did a great job. You asked nice questions. Yeah.
They didn't move your thing because nobody else wants to come on. Yeah.
Good, you're a permanent fixture now. December 5th is when we're thinking about doing the next one. It's going to be in Lancaster. Yeah. Well, good afternoon, everyone. Let's get started because we have people, those who are going to do talking remotely. So we want to bring them on. So this is our last session. Thanks for sticking around after lunch. It's my pleasure to reintroduce Dr. Cody Chastain from Vanderbilt, who is going to speak about what I want from my surgeon.
Wonderful. Thank you so much, Dr. Dave.
Hi, Cody.
All right, everyone. Sorry for that quick technical delay. As far as the title for this talk, I did not necessarily mean for this to come across pejorative or any other. This was actually a talk that, again, Jeff Shook and I spoke about. And originally, when we imagined this session, it was something for us to really discuss in a collaborative fashion about what does an infectious disease specialist want from either a vascular surgery colleague or a podiatrist, or other. What am I looking for from my perspective, and vice versa? What is a podiatrist or vascular surgeon or others looking for me? And so what I probably could have titled this talk, been facilitating best outcomes in limb salvage through collaboration and communication. No new financial disclosures or conflicts of interest. And again, thank you so much to Jeff, Dr. Dave, the conference organizers, and others in preparation. If you look back at the program itself, you'll recognize that one of the goals and objectives was to appreciate communication necessary between different specialties to maximize care. And I really couldn't have put it better than what Dr. Steinberg did at our opening session today. We talked about not being your patient, not being my patient, but being our patient. Because I think if you haven't taken anything else away from the different perspectives and talks today, is that it truly takes a group of professionals with a variety of skills to achieve best outcomes for many of the patients that we care for. In a time that was not in the midst of the COVID-19 pandemic, I might be there physically with you. And I think what will likely work well in the future is actually for this to function as a panel discussion or a case-based discussion and an ongoing back and forth. But what this really has turned out to in the context of our limitations today is that this is really an asynchronous question and answer session through the perspective of surgical calling, asking me a question and me giving my best response. And of course, we'll welcome questions at the end. I mentioned these guidelines before, the International Working Group for Diabetic Foot. I think what's really important to highlight about these guidelines is that this is a very eclectic group of professionals who are all committed to the outcomes for patients, including podiatrists, infectious disease specialists, vascular surgeons, and others who really can speak to the comprehensive care. This is a great source of an example of the type of evidence we should draw on. But I will actually admit that for this particular talk, you won't see as many data slides as you've seen from many of my colleagues as far as a paper, a retrospective study, or a graph. This is really a collection of really my experiences and my engagement with my surgical colleagues. And so a lot what you're going to hear is what's all up in my brain. And as Dr. Kim mentioned, I am biased. I think everything I'm going to say is really, I hope, rooted in data, but it is going to be from my perspective as an infectious disease specialist. I think the other thing to recognize is that we all approach the elephant of limb salvage a little differently. And if we think about the old story of blind men encountering the elephant and touching different parts, and they feel like it's something different. Sometimes when we don't talk and we don't collaborate, we end up being as blind as some of the men working with the elephant. But what I hope is that through the discussions today, what we can do is take away our sunglasses, open our eyes, and recognize that we are all working on the same problem. We are all working together, but we have different skills that we bring to the table. The other thing that I mentioned earlier in response to one of the great questions I received was this idea of benefit and risk. I think anything that we are doing, whether it be medical interventions, whether it be vascular interventions, whether it be surgical interventions, what we're really getting at is the risk and benefit to the patient. And what I want to also say is that no recommendation that I'm going to make is something that is correct all the time. It's all about the balance and risk in the context of that individual patient. So here's a collection of questions that Jeff and I had kicked back and forth in preparing for the session. So when should an infectious disease specialist be consulted regarding limb salvage? Again, a very fundamental question from my perspective. When should my role engage with a podiatrist or a vascular surgeon or a vascular expert? And my tongue-in-cheek answer is that as soon as I or we as infectious disease professionals can improve the care delivered to the patient. I have been incredibly impressed with my podiatry colleagues and many of my vascular surgery and other vascular expert colleagues and how they can comprehensively manage a patient. Many of the things that you all have talked about today, as far as tools at your disposal and knowledge, are things that I'm not familiar with in my expertise. But simultaneously, there are things that I can bring to the table because I spend all of my working time in this space. And so when are times that we as infectious disease specialists can bring additional things to the table? Well, sometimes consulting us at the time of selection of empiric antibiotic therapy may be particularly important, particularly if you have a patient with severe infection and you're worried about progressive disease in that context. Many times you may feel very comfortable prescribing empiric antibiotic therapy, particularly using the principles that we discussed before. Second, you may run into a case that really is highly atypical, either in its presentation, the history, or other aspects of the case. And we can assist in determining optimal diagnostic testing in that context. Third, sometimes we can assist in interpreting either the collection or results of diagnostic studies. And last but not least, certainly if culture data is final, then we can help guide what we think is the best available therapy and the duration of that therapy. But the root of this is that if we can improve the care of the patient, that is when we should enter the fray to assist you. One of the classic questions that, well, what should be cultured? And I think this first statement really takes it. The culture type and timing are really key to effective, meaningful antibiotic stewardship. Antibiotic stewardship is simply this comment that we are choosing the right antibiotic for the right patient at the right time for the right duration. And in doing so, we deliver the best care for that individual patient, but we also preserve antibiotic options for the future for both that individual patient and the community at large. There are many times when culture should not be obtained. If that patient does not have evidence of clinical infection, those are times where culture data actually will not be meaningful. But if cultures are obtained, my experience is that my podiatry colleagues are some of the best at obtaining deep tissue, either by curettage or optic cultures by biopsy, because that gives us the best data to avoid contamination of the field or superficial cultures that may not actually reflect a true underlying infection. In addition to that, patients who have systemic evidence of illness with tachycardia, fever, high white blood cell count, and other things are demonstrating systemic inflammation, and that may actually demonstrate early signs of systemic spread. And in those contexts, blood cultures should be obtained. But I can't emphasize enough that cultures obtained from uninfected wounds, or if they're obtained under non-ideal conditions, such as superficial wound cultures or cultures obtained after antibiotic therapy, We simply need to interpret those results accordingly in the context of the patient as well as in the context of how they were collected. When should antibiotics be started? We actually addressed this when we talked about empiric antibiotics. My takeaway points from my prior session: we should only give it when there's an infection present. We should ideally obtain cultures first. We should assess the severity of a limb infection. And if that patient has a severe infection, we should start to protect the health of that patient. In addition, I fully respect my surgical colleagues if they feel that in the context of their care of the patient, that patient warranted antibiotics because of concern of the depth or the potential spread. All that being said, what additional points can I bring to when should we start antibiotics? Well, again, the type of antibiotics we select and the timing of administration needs to be a careful balance between prioritizing the care of the patient, but also considering how that will affect that patient's care either now or in the future. And again, we want to obtain the best diagnostic data possible because once empiric antibiotics are initiated, it may be more difficult to identify the most specific appropriate antibiotic therapy for that patient and also to limit the duration, which can have an impact on potential harm. I will again emphasize, because I think this is an area where I think there's sometimes tension between surgical colleagues and infectious disease professionals. A lot of times you'll hear infectious disease doctors, well, don't start the antibiotics until you obtain cultures. Don't start the antibiotics until X. Don't start the antibiotics until Y. And what I would say is that delay of antibiotics for the purposes of diagnostic yield should not place a patient at unnecessary risk of harm. And that's where it comes back to this idea that it's our patient. What's the best thing for our patient? Not for necessarily the system, not necessarily for my practice, not necessarily to make it easier for me, but what's best for that patient. And if we approach it as our patient, I think that can make a dramatic step in the right direction. Is debridement necessary as an infectious disease doctor? I will simply turn this question right around and say that's a surgical question that needs a surgeon's answer. That is an area that I would definitely defer to colleagues like Dr. Shook, Dr. Jacobs, and many of you there in the audience. That being said, from an infectious disease specialist perspective, debridement has a lot of benefits. It can provide us diagnostic data in an ideal setting. It can reduce the burden of infectious disease that's present. It can eliminate abscess walls or necrotic tissue barriers that actually may limit the penetrance of antibiotic therapy for optimal outcomes. It can also optimize the wound for future healing. And ultimately, it may actually decrease the need for specific antibiotics or the duration of antibiotics depending on the surgical margin. You say, well, why does an infectious disease doctor care about the margins? And essentially, this comes down to the basic idea that a definitive surgical margin without evidence of infection may reduce the need for antibiotic therapy as a whole. Surgical margins can be defined histologically. They can also be defined microbiologically. But I'll be honest, I can think of only just a handful of cases where I've been able to trust microbiologic data because typically we aren't able to be specific enough about where cultures were obtained in the context of an operation and follow that through to the microbiology lab and to definitively be certain about where certain cultures were obtained and how that reflects things clinically. So typically we are reflecting on a histological read, which as Dr. Kim mentioned earlier, is something that we have to think through thoughtfully and how it's clinically relevant and not simply rely on a pathological interpretation of a tissue specimen. I'm going to show you two outdated slides, and I'm going to emphasize outdated right now because I don't want people to refer back to this presentation and say, oh, well, Dr. Chastain said that this slide is like, this is how long we should. These are two tables I'm going to show from the Clinical Infectious Disease Guidelines for Diabetic Foot Infections from 2012. And one slide's about antibiotic duration for soft tissue, and the next will be about bones. And what I really want to highlight here is just how different the durations can be and how those can be impacted by debridement and potentially amputation with clear surgical margins. The reason I say that these are outdated is that the more studies are done, the more evidence that we acquire, the greater the shift is to shorter courses of antibiotics and a greater shift to oral antibiotics as opposed to IV therapy. So I think if we had a replicative table today, we would see these timelines be shorter and also with oral therapy being considered as an option earlier for more cases. What you can see here is that for soft tissue infection, therapy can range from oral therapy to IV therapy for 1 week to 2 weeks to 3 weeks, maybe even longer. On the next page, however, if you look at bone and joint diabetic foot infections, look here. At the top line, no residual infection after amputation. Parenteral or oral therapy for 2 to 5 days. And actually in the new International Working Group guidance, they simply say for a short period of time or several days. What about if there's residual soft tissue infection, but all infected bone was resected? Well, we can treat that as a soft tissue infection, not as a bone infection. What if the bone is debrided, but it remains as viable but infected bone? Well, then we treat that as osteomyelitis. And this last year, you can see if there's actually necrotic, unresected infected bone, historically, very long courses of antibiotics are recommended. I do not believe today that our guidelines would say greater or equal to 3 months. I don't think that there's likely curative benefit of antibiotics beyond 6 weeks that have been demonstrated by studies. That being said, there are cases where suppressive antibiotics may be necessary in certain select cases. But the main point of me showing you those 2 slides is to really emphasize the fact that antibiotic courses and durations are dramatically impacted based on what may or may not be done through debridement or in the operating room. Well, the patient needs extended antibiotic therapy. And what do I do now? Well, I hope that in your local care community that you have a local infectious diseases specialist who is both accessible and helpful. And owning my specialty as a whole, we are made up of people. So just as surgeons are made up of groups of people and podiatrists are made up of groups of people, there are fantastic ones to work with. And there are some that are more challenging from either a personality or from the standpoint of accessibility. But my hope is that if a patient requires an extended course of antibiotic therapy, whether it be an IV course or oral course, that you can work together to coordinate outpatient follow-up and really emphasize clear and direct communication, both when concerns arise and also what you find. There's nothing more helpful to me as an infectious disease doctor than hearing from the surgeon in the post-op recovery area about what happened in the operation and what they saw and what they did. There is not a single piece of data that I get back from the microbiology lab that is more important to my clinical decision-making than that discussion. If collaboration is not possible, either because the access to an infectious disease physician or because the individual that you have the opportunity of working with is not very collaborative, there's a couple things I want you to think about in context of the best care of the patient. I fully recognize this may not be your responsibility in a typical care environment, but I also recognize that some of you may work in environments where you don't have the appropriate level of support. And as Dr. Jacobs mentioned before, many of the podiatrists in the audience are the generalists. There are so many things that you are aware of and are also skilled at delivering in care. The 3 areas that I always focus on when counseling patients is ensuring that appropriate laboratory monitoring is ordered if needed. Many IV antibiotics have potential hematologic, renal, or hepatic toxicities, and subspecialty pharmacies that include pharmacists can often assist in monitoring those labs as well as adjusting doses. Second, if a patient requires IV antibiotic therapy, whether it be through a peripherally inserted central catheter or another central line access, patients need to be counseled about the potential for deep vein thrombosis, as well as bloodstream infections that can enter the area, and to be counseled about how to notify others if they notice swelling, redness, or other symptoms. And last but not least, there needs to be an action plan discussed with patients about who do they call, who do they contact. If they develop severe diarrhea while on antibiotics, and we as clinicians would be concerned about Clostridioides difficile, well, who are they going to call? Who are they going to contact? If they develop what they think is a side effect from antibiotics, who should they call and how do they contact them? These are all important things, and this is where I think as a community, we should provide care to patients. But again, things to think about if your care community isn't holding up their end of the bargain. Ultimately, in the big picture, limb salvage is a puzzle. It is requiring a team of experts to address limb ischemia, to address wound care, to address offloading, and to address infection if present. And so hopefully this gives you some context from an infectious disease specialist about how I approach patients and how I hope that you can collaborate with colleagues in your home community. Again, if you've got questions, don't hesitate to email me here below. I'm happy to take any live questions at this time.
Thank you very much, Cody, for that wonderful presentation. Brian, how does things work at in Lehigh Valley? It's a huge system. You know, how's the collaboration between wounds and ID?
I think our ID folks are excellent, and finally, I think we've gotten a team which is big enough to tackle this very big problem. And they spend a lot of time in the wound center evaluating patients, which is really fantastic.
So, does your wound people call them on site, or this is only possible when they are admitted in the hospital?
Usually, when they're admitted in the hospital, occasionally they'll come to the wound center, directly, but usually it's a phone conversation.
Any other comments from any other panel members? Okay. All right. Well, thank you very much, Dr. Chastain. Great job, as always. It was great to see you. And we'll continue with the program. It's now my privilege to introduce Dr. Alan Jacobs. I have had privilege of having a long association with Dr. Jacobs because of C3 meeting. He's been a C3 faculty for many, many years. And he will do the next lecture on antibiotics with limited surgery for forefoot osteomyelitis.
I'm going to combine the last two lectures, if it's okay, and save
Sure.
the question for the end.
Sure.
Always enjoy listening to Dr. Chastain, especially his selection of words, such as maybe some people could be more challenging to work with. He's a lot more charitable than I am, but again, being raised in Philadelphia and going to Eagle games, the word that he selects perhaps isn't quite as received. But in any event, I want to talk about one area that may be controversial. I was fascinated to hear about the increased emphasis on oral antibiotic therapy for treating a variety of these problems. And I would say one other thing, having had the opportunity to review many, many charts, I think if you are managing some of these infections, I think we need to get more laboratory studies, as Jeff mentioned, CRPs and SED rates and temperatures and white cell counts and so forth. But I want to talk about this issue of treating oral osteomyelitis just with oral antibiotics. And what I'm going to say is that if you look at the data available, you have similar rates of cure generally, whether you treat osteomyelitis in general. Of course, there are exceptions, orally or parenterally. We know that even with parenteral antibiotics, the cure rates are not 100%. There's increasing pharmacokinetic data that says oral antibiotics are very much appropriate. And the biggest thing is looking at the patient themselves. Generally, I look at oral antibiotics and discuss this with my ID colleagues here in St. Louis. If I have a generally immunocompetent patient, they have adequate vascular supply and compliance, because one of the biggest downfalls of oral therapy is the fact that study after study has shown us that many of our patients don't take all the medication we prescribe. So 4 a day becomes 3 a day, or 2 a day, or sometimes 2 a day, 3 a day, sometimes 4 a day. And it makes it difficult. Now, it's interesting that, to my knowledge, unless Dr. Chastain wants to correct me, there have been no new antibiotics approved specifically for treating osteomyelitis for at least 15 years. There's very few specific practice guidelines. And again, we know that there's high rates of treatment failure, but it's been suggested that the number one cause of treatment failure is failure to obtain adequate debridement. Jeff mentioned a patient that had gone, I think it was Jeff, to a wound care center for 2 years, failed to resolve this wound that they had been treating. And again, oftentimes these are limb-threatening problems. These things can be difficult to treat and at times difficult to diagnose. I have seen more than one ulceration associated with neuropathic arthritis of the forefoot, so-called diabetic osteolysis or type 1 Charcot joint disease that has been automatically called osteomyelitis. And even with good pathology, even with biopsies, especially in these Charcot patients, I have a couple in the house right now. These could be difficult calls. Is it Charcot? Is it osteo? And even with all we know, they can be difficult. And you don't have a whole lot of good literature to give you guidance. There are obvious advantages to oral antibiotics, and the biggest one, of course, is anyone listening, including myself, would much rather take pills than go home with a PICC line. The problem, again, is compliance and whether or not you have a patient in front of you that understands the significance of their problem and is willing to take responsibility. And I bring the family in on this too. And again, the biggest thing here, I can't overemphasize this, is compliance. And all of you know that. We have patients that we talk to and talk to and talk to, and they still continue to weight bear on their foot. They continue to eat poorly. They come in with A1Cs of 12 and 13 and want us to effect a miracle cure. The other disadvantage of orals is obviously it's probably less predictable. Some of the things I look at, I think we pretty much know that cancellous bone will achieve higher levels of antibiotics, both oral and parenteral, than cortical bone. And when you have an acute inflammatory process, by definition, since you have increased vascular supply to that area, you have increased penetration of the antibiotics. So whether we look at acute or chronic, however you want to define acute osteo versus chronic osteo, the bottom line is antibiotics plus or minus debridement. The goals of debridement, one thing I would have added to one of Dr. Chastain's slides regarding debridement is the ability to reach vascularized bone. So we want to remove that dead necrotic avascular bone so the antibiotics could penetrate to there. And then we have, of course, the other issues that he raised. And of course, getting clean margin cultures, I think that's always important. And maybe even clean margin cultures and pathology. I remember early in my career working with the ID people from St. Louis University. I would come out of the OR as a young surgeon and they'd say, "What did you find?" And I'd say, "Oh, I got it all. Good hard bone and it was clean." And they would look at me and say, "So you could see the germs." And of course, I came to realize what they were speaking about. And I think one of the good reasons to use prophylactic polymethylmethacrylate antibiotic impregnated spacers is for that residual osteomyelitis, not so much to affect a cure. Dr. Steinberg talked about his evolution back to non-absorbable antibiotic-loaded bone cement. I still use absorbable beads if I'm curating out a large portion of medullary bone or leaving a large bone defect where I'm worried about fracture, because we know the elution properties of antibiotics are better with absorbable beads such as calcium phosphate or similar products. And it is also osteoconductive, so it does give us the opportunity to grow bone while treating the infection. There are many classification systems for osteomyelitis, walled vocal and so forth. And I like the Cyrenemator for one reason. I think a lot of what we treat in podiatry is really not true osteomyelitis. We have an ulcer, we have contiguous spread, and we may have infection either just to the outer portion of the bone or focally in that bone, but it's not all the way up and down the medullary canal. And it's a lot easier, I think, for us to treat these problems than, for example, orthopedic spine treating osteovertebral body, where you can't just go in and throw out 3 or 4 vertebral bodies. The traditional standard of care was discussed by Dr. Chastain. It was based on the theory that it takes bone a while to finally revascularize. The current standards really go back a long way. And again, the cure rates are not 100%. The Infectious Disease Society of America, to my knowledge, does not have specific guidelines for treatment of osteomyelitis. For MRSA, they do have guidelines, and it's kind of interesting that if you look at that, not specifically for osteo, but for MRSA in general, there is room for appropriate oral antibiotic therapy. And the fact is that there's no real evidence that parenteral antibiotics are superior. Similarly, if we look at some classic works, for example, diabetic foot infection guidelines, not specifically referring to osteo, but infections in general, as Dr. Chastain pointed out, there's increasing data to show that in properly selected patients with the right bug and the right drug, that we can affect a cure with orals as well as parenteral. One of the things that always goes through my mind in the forefoot has been alluded to previously. I think once we lose that first ray, we now know it's only a matter of time until we develop flexion contractures of those other toes, distal or dorsal ulcers, or we have transfer lesions and we get transfer ulceration. And I think many feet tolerate the resection of one lesser metatarsal pretty well, but I think we all know that when you start resecting bones, and especially in the forefoot, the patient weighs the same amount. That weight has to go somewhere, and we end up with these types of problems with transfer ulceration. So we have someone like Dr. Dave, and they spend lots of time and lots of skill and lots of money to revascularize and reperfuse these patients, and we get an initial healing of the original ulcer, or we get a forefoot amputation to heal, and then they come back with these transfer ulcers. And this is made worse with neuropathy. We know that neuropathy patients do very poorly, much more so than patients without neuropathy, not only because of sensory neuropathy, but we got to remember most of these patients have motor neuropathy, so they have lack of stability and deformities from their motor neuropathy, and very often have skin like this from autonomic neuropathy. So they have vasomotor and pseudomotor dysfunction, and their skin is less able to tolerate pressure. So we end up with a healed first ray amputation, multiple contractures, and transfer lesions. And we all know that the data is there to show that a high percentage of patients that undergo first ray amputations end up requiring a revision. That in mind, we do have this classic study that you may or may not have seen. It goes back to 2014. Other studies have been published since then, but I want to go back to the classic. And this was a study of treating forefoot osteomyelitis with either antibiotics alone, and some of the patients had no cultures. Actually, there was a presumptive diagnosis of the organism and the diagnosis, or surgery. And these were all forefoot ulcers, something that we all commonly see. And you could see that the patients that were treated with antibiotics alone had a 75% success rate, but I call your attention to the re-ulceration rate, which was just under 10%. Whereas when we start taking off toes and metatarsals, that re-ulceration rate is 1 in 5, and probably higher than that. So if there's a way to preserve that forefoot anatomy by using antibiotics alone, perhaps getting a culture to assure we're giving proper antibiotics, but preserving that anatomy, I think there's a strong argument to be made by that. Looking at the Cochrane database on the use of oral antibiotics for the treatment of osteomyelitis, there's really not enough data, although what is available, again, points to no difference in outcome between oral and parenteral antibiotics. Dr. Chastain spoke about the organisms, and if we're going to make a presumptive diagnosis, although diabetic foot infections tend to be polymicrobial, we know that the major players are almost always going to be gram-positive organisms. Looking at oral antibiotics that have been documented for the treatment of osteomyelitis, I've got some of them listed here. Tadizolid has not been described, and I just added it because with linezolid, For treating osteo, we have all the issues that go with linazolid, serotonin syndrome, and irreversible neuropathy and thrombocytopenia, and all these kind of things, whereas tadalafil will bypass that, but I'm not aware of any studies specifically utilizing that. Ciprofloxacin has been shown to have reasonably good bone penetration. There's now black box warnings on Cipro, and as you know, you've got to be very careful with these patients that have dysrhythmias. You can get an irreversible neuropathy, tendon ruptures, and a lot of neuropsychiatric side effects, and we now have this so-called quinolone disability syndrome. So I'm not quite as quick as some of my colleagues to pull out the Cipro or the levofloxacin, but if it's appropriate, particularly from gram negatives. Trimethoprim sulfamethoxazole, again, in our diabetic patients, renal function, sulfa allergy, this type of things, but good literature to support the use of trimethoprim sulfamethoxazole orally for the treatment of osteomyelitis, good studies for using linazolid for osteomyelitis with reasonable cure rates and excellent bone penetration. Clindamycin seems to have been best studied in pediatric osteomyelitis, but again, good bone penetration. Obviously, you're going to monitor the patient for the potential side effects, make sure they don't have inducible resistance and so forth. The tetracyclines, I think a lot of us are using the doxycycline now, and once again, good bone penetration, good availability, and like any antibiotic, potential side effects. Metronidazole for anaerobic osteomyelitis. Now, all of the studies supporting oral antibiotic use for osteomyelitis treatment do have their flaws. They had varying endpoints. Some of these studies were very, very small, no standard follow-up. I mean, you could see this list, and these are the problems that we have, but we do have a significant body of literature now to support the use of this, and I think in forefoot, this is particularly useful because once we disrupt that anatomy, transfer lesions are occurring in at least 50% of these patients. So when are oral antibiotics appropriate? An immunocompetent patient, and that includes adequate vascular perfusion. They've got to be a compliant patient. I think they're better for acute than chronic osteomyelitis. When they might not be appropriate, significantly immunocompromised patients, patients with critical limb ischemia, gangrene, obviously, and general medical issues that would preclude doing that. So in summary, it looks like there's increasing literature to suggest that we have similar rates of cure for osteomyelitis, whether it's oral or parenteral. IV cure rates are not perfect. And again, I would say the most common cause of failure is probably failure to obtain adequate debridement. But adequate debridement often requires resection of so much bone that we end up with the inevitable transfer ulcer. I remember as a student, before podiatry was really integrated into general medicine, and ID was not what it is today. In fact, I think I'm so old, I'm not sure there were ID specialists back then, Cody. But I remember as a student looking at these ulcers, and to me, from a mechanical standpoint, it was obvious why these patients were ulcerating. They had a hammer toe rubbing on a shoe or a bunion, whatever. And I would hear these physicians saying, it's inevitable, you can't cure these diabetics, they just get one ulcer after the other. And that was the basis upon which all these below the knee amputations were being performed. So you got to have the right patient. So is there going to be a change? I think so. I think we're seeing it. I was surprised to hear, I'm happy to hear Dr. Chastain's endorsement for using orals under some circumstances, because again, I remember when it was 6 weeks parenteral at a bactericidal level, and that was the absolute rule, and there was no changing that whatsoever. Lastly, I want to end with a discussion that I also think is pretty important, and that is after the intervention. So we have our patient, we've picked up peripheral arterial disease, we sent them to the interventionalist, they've had their interventional procedure performed. We've got increased blood flow. Now what do we do to keep them healed? So when we are faced with ischemia, we have multiple choices. And obviously revascularization or a percutaneous procedure is going to be preferable if possible, or you want to debride that patient back so that there's no necrotic tissue. Here again, to allow healing to occur, allow antibiotics to penetrate to the area we need to penetrate. That means amputating to an adequate level of circulation. I was a little surprised at the new International Working Group on the Diabetic Foot suggesting that hyperbaric oxygen is
I think that the connection is lost. So while we get Dr. Jacobs back, any comments about the prior issue of antibiotics and empiric antibiotics versus calling ID every time?
Yeah, I think there is one thing to say about this, and if you look at some of the international literature, specifically with respect to forefoot wounds and infections and such, it's definitely beneficial to try to approach these patients with the object to save as much anatomy as you can. And when I say that, I mean that you're not just going to cut out all the bad tissue and then put them on antibiotics, but perhaps if someone has osteo, the medial aspect of the first metatarsal head, instead of taking out all the metatarsal head, you take out the medial 1/3, get it to a reasonable margin, and then treat the patients with antibiotics. There's a big difference between having a staked first metatarsal head and having no metatarsal head. And I think I see that as kind of the direction that some groups are heading in. It's not for everybody, but there certainly are patients that would benefit from that type of approach as opposed to taking out the metatarsal head. And I think it's really important with respect to the first MPJ. Not so much the lesser MPJs. It's important there, but it's really important with the first MPJ.
Dr. Richard?
Jeff, are you all able to hear me?
Yes, we can hear you.
Hey, I was lurking in the background, hoping to pipe in
That's an ID thing.
with some of Alan's comments. From an infectious disease standpoint, I couldn't agree more with Alan's presentation about the role of oral antibiotics moving forward. The only thing I would disagree with in his presentation is that I have a way with words more than he does. Overall, I would say that oral antibiotics absolutely have a role moving forward, probably not just for osteomyelitis, but I think each time we study this, it's really a question, is there a difference for the pathogen? Is there a difference for the penetration of the tissue? Is it orally bioavailable? Once it's into the bloodstream and it can penetrate into the bone or other tissue, there's nothing magical about IV antibiotics otherwise. One of the specific studies that I would encourage folks in the audience to review if they feel uncomfortable with this process or to challenge their friendly challenge to their ID colleagues locally is the oral versus IV antibiotic study for bone and joint infection that was published in the New England Journal of Medicine in January of 2019. The lead author was H.K. Lee, last name spelled L-I. And that definitively showed that in a typical use clinical context that there was no difference between oral and IV antibiotics as that was administered. And so I think in the big picture, just like Alan was saying, we can get all the benefits. And again, coming back to Dr. Kim's point earlier, a lot of this has to do with the host, and a lot of it has to do with how we control these other factors, including ischemia, including wound offloading, including wound care, as opposed to antibiotics themselves. So I really just wanted to reinforce a lot of the points that he was making about, yes, I think oral antibiotics are appropriate in many cases. There's one major exception that I think is the case, is that if we think that that infection started in the foot or the limb spreads into the bloodstream, in that context, IV antibiotics are typically appropriate. Or if we think that infection got to the foot through the bloodstream, then that would be different. And that's why the MRSA guidelines specifically comment on IV antibiotics being preferred, mainly because of the risk of endocarditis and vascular infection.
No, that's great, Dr. Chastain. I do have a question for you. Do you think that the patient, those who are not able to be revascularized versus those who are able to be revascularized, there's a difference in the effectiveness of antibiotics for the infection?
Yeah. So I would say, I would agree with you, Dr. David, that there is probably a difference in the efficacy of antibiotics, but it's a purely mechanical relationship as far as the distribution of that antibiotic. When we talk about oral versus IV antibiotics, some oral antibiotics get 90% of the bioavailability into the bloodstream that an IV antibiotic does. In that context, virtually there's no difference versus oral versus IV. With a patient with critical limb ischemia, there may be significant delivery issues of anything to that foot. And so in that context, I think that antibiotics may be limited, but I don't think that's necessarily something we have to discriminate between oral versus IV antibiotics, even in those ischemic patients. On the other hand, if you choose an oral antibiotic that only 10% or 20% get into the bloodstream from the oral tablet, as compared to 100% that's administered through an IV, then that's obviously a big difference. And so that's where I think the emphasis has to come down to what antibiotic we're selecting. And going back to my prior lecture about oral bioavailability, that makes a big difference when we're making a discrimination. So in short, does ischemic limbs make a difference for infection outcomes? I think it does. Does it make a difference between choosing between oral and IV antibiotics? I would say no, unless your oral antibiotic is not orally bioavailable, because then that's when it's a mathematical problem. A percentage of the percentage gets to the foot.
So
Great.
I have a quick question for you, Dr. Chastain. As a podiatric surgeon, would you like to see us using more of the antibiotic beads? Would that help from an ID standpoint in terms of how much oral or IV antibiotic the patient would need with osteomyelitis?
Yeah, so I think that Dr. Rich has got a great point as far as antibiotic beads, and this also comes back to some of the discussion earlier, Dr. Steinberg, about antibiotic impregnated cements or other implants. And I think that at this point, what we have is that there is emerging literature for the use of impregnated cement, beads, others, that these, at least based on case series data and single center studies, seem to have improved outcomes. I think the challenge is we don't have adequate randomized studies to compare. Is that something that's just observed and has all the positive outcomes have to do with the other skills of those surgeons, of those groups, and how they care for those patients comprehensively? Or is there a dramatic difference? There are some smaller studies that have done some comparisons that seem to suggest improvements. I will also think, going back to my theme of balancing risk and benefits, I think that antibiotic impregnated cements and bead use have demonstrated to be very safe for patient use, and they don't seem to be harmful. So I think in this context, I appreciate when my surgical colleagues do all they can to breed and also potentially implant. That being said, it's not to the point where I feel like it shortens how I'm going to treat the patient otherwise, but it may improve outcomes. Okay. That's a great point. And actually, Dr. Richards, I also just wanted to follow up on your question earlier about bone biopsies. I couldn't get back into the Zoom room in time to weigh in along with Dr. Shook, but I would absolutely echo what Dr. Shook had mentioned before about the role of routine bone biopsies. Again, looking at benefit and risk, I think bone biopsies have actual risks as far as compromising the structure of bone and introducing infection. And my question would always be, how is this going to change my management? If a wound does not go down the bone, if I have no clinical intuition that there is infected bone, there's nothing on imaging to suggest that there's something in the bone, I'm just as likely to say that positive culture is actually going to be picked up along the track or a contamination than actually being in the bone itself. And so I think I would say that are bone biopsies helpful? Absolutely, they're helpful in patients who have clinically failed appropriately courses of therapy. As a routine measure, when we don't think that the bone is involved, I would wonder or I would worry that the risk might outweigh that.
Thank you.
Yes.
For Dr. Chastain, if you can hear me, I apologize in advance if you covered this in the first lecture. I had to walk out for a minute. But does anybody get concerned with development of C. diff with longer term or with oral antibiotics as opposed to IV? I had 2 patients this week who are a bit elderly, and maybe you would just consider them compromised, and they don't have severe infection. I found myself backing off a little bit from the antibiotics I gave them because I was getting concerned about C. diff.
So just so that I repeat the question is there a concern about C. diff if we do a prolonged therapy with oral antibiotics from the audience?
Okay, thank you. I wasn't sure if that was directed to me or otherwise. What I would say is that Prolonged antibiotics of any kind, whether it be parenteral through an IV or oral, can also be a risk of Clostridium difficile infection. There are certain antibiotics that seem to have a higher predilection and have been attributed, such as things like clindamycin and fluoroquinolones. However, with additional studies, it seems that most antibiotics increase the risk, and I would not discern my choice of oral versus IV antibiotics on the basis of C. diff risk. I think you are absolutely appropriate to be considerate about, does a longer course of antibiotics put patients at risk? Yes, and that needs to be part of that risk and benefit, but it would not push me or sway me between choosing between IV and IV.
Thank you very much. I see Dr. Jacobs now back with us to finish his presentation.
And Dr. Jacobs, I was simply agreeing with everything that you had said before, except for my way with words.
Oh, no, you have great choice of words, but you're not from Philadelphia, obviously. Well, let me see if I can do this one more time. I apologize.
That's okay.
I'm not sure what happened. Let's see here. Actually, I'm not even sure how far I had made it to there. So I guess my summary really was that in preventing recidivism of these ulcers, the important thing is, of course, the factors we discussed, which is assuring vascular flow, and then choosing a functional amputation. And I would argue that once the first ray goes or multiple lesser ray goes, that a transmetatarsal is the most durable functional amputation that we do. Dr. Chastain said that his last lecture had a lot of personal observation, and I do too in this, and I would say that in my experience, a good TMA followed properly with appropriate inserts and shoeing lasts the patient pretty much a lifetime. And then lastly, trying to avoid expensive wound care products. We are being marketed heavily with miracle cures, and I don't know if I had a chance to say that before I was lost or not, but I was surprised that the new international working group on the diabetic foot included amniotic grafting, systemic oxygen therapy, and PRP as adjunctive therapies. Personally, I think good debridement, recognizing infection when it's present, nutritional considerations, proper offloading are the keys to, and of course, making sure vascular perfusion is adequate are the keys to healing these wounds and preventing recidivism.
Thank you very much, Dr. Jacobs. Any final comments from panel on the left side?
Can I ask a question?
Sure.
Of both the interventionalists and Dr. Jacobs. Can someone discuss, after the intervention, someone's had an angioplasty, even a bypass, when and how quickly do you order non-invasive vascular studies? Could you talk about that a little bit in the patients?
I think that's very important. You know, the first thing I tell the patient when I see them for a critical limb ischemia is that I tell them that there is no chance of us not meeting again. You know, it's given that they will require repeat procedure, especially if we are working on the arteries below the knee, because those in that bed, the current technology does not produce a very durable outcome. So if you have a large wound that usually takes 6 months to heal, you know, you almost are guaranteed required to re-intervene on that patient. And that means that in early Doppler examination within 4 to 8 weeks of time is must to look at that artery, whether the artery is open or not. Obviously, just a femoral artery intervention, then there is no need for a Doppler that quickly because the femoral artery intervention is a lot more durable intervention than something below the knee. And if the patient comes back in 4 to 6 weeks and the wound is healing really nicely, then sometimes even if the artery may have restenosis, I may not do anything. And have him come back again in another 8 weeks' time and see if it's getting worse. But I always tell the patient that the repeat intervention is very likely, and they will need a very close follow-up.
But I'm not sure you need non-invasive vascular studies. To me, the barometer is actually the people who have their eyes on the wound. And they can really tell me whether I'm open or not. And, that's the thing that gets me back either to a non-invasive study or maybe directly to another, angiography.
Can I follow up on that just real quick? So if I have a patient that you've revascularized for me and I'm seeing them 6 weeks after the revascularization, and initially the wound was doing poorly and now there's a problem. Option A is to send them to you and you take them in for angio and do whatever needs to be done. Or option B, do you have a problem with me sending them for non-invasive vascular? You just want the process started.
Yeah, I'm going to have to disagree with Brian on this one because I do think that non-invasive study is important because if they have a significant size wound and it's very important to keep that straight line flow open. So my threshold for repeating the vascular study is actually very, very low. Yeah. So I would, and whether it's you order it or I order it doesn't matter. But I think that if one in doubt, I would do that.
And there's
And it is reimbursable. Yes, sir.
Sorry.
In our institution, we do a lot of CT angiography.
Sure.
I think they are pretty good at delivering salvage process or cardiac process. It's pretty good resolution.
Yeah. The only thing is that it's a hassle, to send patient to the, hospital for a CAT scan. I have vascular lab in my office where I see the patient. And now it's not like that I can, get Doppler study on every patient that walks to the office on the same day because there's already a scheduled patient load for the vascular lab. But, it's very easy to get a vascular study than sending the patient for a CTA. Now, for a patient, for someone like Dr. Cody, who has an outpatient lab where he has a contrast angiography available where he sits, I'd actually recommend that, another contrast angiogram in 6 to 8 weeks should be performed, and that would be very, very justifiable thing to do, to look at, especially below knee revascularization. I work in a hospital system, so for me, to bring patient, for a contrast angio is not simple. It's got to go through, documentation, blood work, all kinds of things before I can bring patient to the lab. Okay. Well, thank you very much. First of all, I want to thank all the faculty members. I know Dr. Richard's been very brave and has brave enough to be here for several hours with us, and Dr. Cluck, who's taken very long trip in the middle of a very busy week. Dr. Jacobs, thank you again for his contribution. Dr. Shook, who's driven here all the way from West Virginia, also took a lot of pain to be here. Dr. Harrison, thank you very much, and all the other faculty, those who are in the audience. So I really appreciate it. It was a great program. I wish you all well. Have great holidays. Hopefully, by the time we see you next time, we're going to be in a different circumstances. We won't require this 6 foot distancing and so many masks and such a limitation on our number of attendees we can have. And thanks to all the industry partners who has very generously supported this program. Without them, we could not do this. So we look forward to seeing you next time. Thank you very much.
Thank you.